Okay, I'd like to welcome everyone to the July 27th, 2020 meeting of the Delaware County Board of Commissioners. Would you please rise and join me in the pledge? Actually, Sheriff, would you lead us in the pledge?
Absolutely. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, thank you, Sheriff. Jeff Benton, President of the Board. To my right is our Vice President, Gary Merrill, and our Administrator, Mike Fromer. To my left is our fellow Commissioner, Barb Lewis. And Jennifer is the clerk today, so let's start.
Resolution number 20-627, in the matter of approving the electronic record of proceedings from regular meeting held July 23rd, 2020.
So move.
Second. Discussion. Vote.
Vote on motion 20-627. Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Mr. Benton?
Aye.
Resolution number 20-628, in the matter of approving purchase orders.
So moved.
Second.
Discussion. Vote.
Vote on motion 20-628. Mrs. Lewis?
Aye.
Mr. Merrill?
Aye.
Mr. Benton?
Aye.
Next on our agenda, we have Sheriff Martin and Cassie Neff with the Delaware County Criminal Justice Programs Manager with an update on the Reentry Coalition and the jail.
Good
Welcome.
morning. Thank you for having me. As you said, my name is Cassie Neff. I work with the Delaware County Sheriff's Office, and I am the Criminal Justice Program Manager. I'm housed in the jail, so I oversee all of our inmate programs that include mental health, substance abuse, reentry planning, education, and employment readiness. And I am also our county's Stepping Up Coordinator, which, as you know, is a national initiative to reduce the number of people with mental health issues and substance use issues from the jail and get them connected to a path of recovery. So everything that I'm talking about this morning is absolutely in support of our Stepping Up initiative.
Good morning, Sheriff Russ Martin, Delaware County Sheriff's Office, and just appreciate the opportunity, obviously, to give you a kind of a briefing of what we're doing out in the jail. The jail requires about a third of our overall budget to meet statutory requirements, so I think it's important to keep the commissioners posted. So when the COVID experience began several months ago, I was really proud that how quickly jail staff responded to that. And we began screening all personnel entering the jail, both inmates and staff. Additional efforts were made to clean the facility. It's already, we think, an outstanding facility, but they took extra precautions with particular products to decontaminate areas, anything that was touched. All jail staff began wearing masks back in early April, and along with taking daily temperatures of staff members as well. We continued also to take those temperatures of inmates too, and began modifying the way that we provided inmate care, and Cassie will go into greater detail on that. One of the things that we determined early on was to work with our criminal justice partners, the courts and the prosecutor's office, in an attempt to reduce the overall jail population, to reduce the opportunity for a spread of a virus or of COVID in particular. And we went from 220 inmates to 90 within a few weeks. Now, I want to keep in mind that those inmates were already serving time, had served time, low-level offenders, maybe somebody in there who had a few days left on a DUI. We worked with the probation department, so nobody that we deemed, along with our partners, who was a threat to society was released. Those were people that were paying basically their debt to court. And so we went from 220 to 90. And it wasn't just to only reduce the number of people in the jail, but it was also to open up some areas of housing that could be created for isolation if we needed to do that. And then we've been following the guidance of our local general health district, the health directors out there in the hallway. We've got a great working relationship with her and have been working with her regularly. And our jail doctor happens to have a master's degree in public health. I don't think we knew that until this pandemic came. So we've got great support out there. But overall, really proud of the work the staff has done. Cassie's going to give you a little bit more information on what we've been doing, and grateful for the partnership we've got with this board in particular Commissioner Lewis and the introduction she made several years ago to Justice Stratton on the Stepping Up initiative. I'm here to tell you that to date, and we've been really blessed, really fortunate that we've not had a positive COVID test in the jail, inmate or staff. Now we know that could change in a moment's notice, and regrettably, on my way to work this morning, I was briefed. We had a corrections officer who was taken by emergency services to the hospital this morning, may have had an exposure to fentanyl from an inmate who was being brought in this morning. So there's still risk in the jail. COVID's still out there, but I can't tell you how proud I am of staff, and Cassie's going to share a little bit more about what we've been doing there.
So I want to talk a little bit about what the jail program looks like.
Cassie, if you could, we're on,
We're recording it.
we're recording. Yeah, thank you.
So first, I'm going to talk a little bit about what the jail programs looked like prior to the pandemic. So give you a brief overview. We were operating 50 hours of programming per week. That is fairly unique for a county jail. How we did that is we relied heavily on our community partners and volunteers. So that is one of my primary responsibilities, is to manage that 150 pool of community partners and volunteers. So they were coming into the jail really Monday through Sunday, first shift and second shift. We were providing mental health counseling, substance abuse treatment groups, and reentry planning. All of that is comprised in what we call the LINC program, LINC, Lives in Need of Connection. So individuals returning to Delaware and Morrow County received, they were connected with a counselor in jail, and if they wanted to follow up with that same counselor upon release, they could. That was very important to make sure we established those relationships in the jail. They also received a designated case manager, and then we would start to develop their reentry plan prior to jail and then help them execute it upon release. We would arrange transportation to pick them up in the jail lobby. We would take them to their probation officer, take them to the food pantries, arrange direct, get them right into treatment upon jail, and then get them into sober living. So every plan looked very, very different, but it was intense case management. For that program, we are yielding successful data. So individuals that participate in the LINC program were 30% less likely to come back to jail as compared to the general population. We also had education programs that's provided by the Delaware Area Career Center, and we had support groups for survivors of human trafficking. That was provided by Salvation Army. We also ran 12-step meetings, NA meetings, and 11 different Bible studies represented from 7 different local congregations. We created a unique program called the Grace Navigation Program. So this is not a Bible study, but it is provided by Bible study instructors. The idea around this is to connect people to resources through relationships. So those individuals were coming into, the volunteers were coming into the jail every week, and they would run a group, and it would be some soft skills, so goal management, relationship building, some financial classes, but really they would listen to the inmates and hear their issues and problems, and these people were already trained about community resources. So if they could hear somebody talking about struggling with mental health or struggling with benefits, those volunteers could connect them to Job and Family Services or connect them to a community provider right there in the jail. We also developed a reentry resource guide. This is specific to people coming out of jail and prison. This is amazing because I would do hours of research for each person because everybody is very different and their needs are very different. And it was getting, it was just not easy to organize. So my colleagues also struggled with the same thing. And we were like, why don't we have one document that is convenient to put all these resources together so that it's easy accessible for our clients, but then keeps all of the professionals on the same page with the most current information? So we did. We created this pocket resource guide, and I have a couple if you are interested in receiving that or if you work with people that may benefit from it. This was wonderful because we actually rolled this out to the public last week, but it was finalized in March. So during the pandemic, I was able to give this to the inmates who were getting out so that they could get connected to resources.
Yeah, we saw the resource guide probably a month ago,
Uh-huh,
something like
right,
that.
right.
Very clever, very well laid out.
Yes.
So, yeah.
Yes, thank you. It was a collaborative effort between the, all members of the Delaware County Reentry Coalition.
Yeah, yeah.
Should work very well, very helpful.
It's been a success so far, yes.
Great.
So now I'm going to talk about screening in the jail. So how do individuals with their mental health and substance abuse and reentry needs come to me? They are screened. So the picture to your left is Angie Destheimer. She's a classification clerk in the jail, and every individual that is booked into the jail for 72 hours or more receives 2 behavioral health screens. The first is a brief jail mental health screen, and the second is a substance use screen. It's actually called the Texas Christian University Instrument. These screens for individuals that flag or are positive for having issues with that, they're recorded in our jail electronic management system, so that data is already pinged to myself as well as other divisions in the jail, such as mental health and the medical division. That's how my referrals are generated. It's also wonderful because we can use this data in aggregate form to evaluate the different programs that we're doing. Especially for our Stepping Up initiative, we want to know, are we reducing the number of people with mental health and substance abuse issues in the jail? Are we getting them connected to resources? So because of these screens, we're able to use that data to evaluate that. We also screen for veterans. We have changed the way that we ask people if they've served in the military. We used to ask, are you a veteran? We now know that that can result in not the most accurate information. So there's stigma associated with that, especially for somebody who is discharged not honorably. So now we ask, have you served in the military? And by the way, thank you. From people answering, that goes into our electronic management system, and much like the behavioral health screens that I just explained, that automatically computes a list that is emailed to all of our community partners. But in addition, our classification clerks are entering every single person that's booked into the jail into the Department of Defense system. So this is what they call the Veteran Reentry Resource Service. Sorry, I had to get that
That's
acronym
really
right.
good.
But that way, this is how we are compliant with HIPAA. So the jail is inputting all of the people booked into the jail to the Department of Defense. Then the Department of Defense is cross-referencing that list. They figure out who the veterans are, and then they send, his name is Bobby Perkins, and he is the Veterans Injustice Specialist. So he comes into the jail. Now we're setting up virtual visits, but he'll work with all of the veterans getting out. He also works with Judge Himmeter's Mission Court, which is a veteran's specialized docket. So when the pandemic hit in March, this is me working remotely from home, and those are my 2 baby girls, Reagan and Reese. That was challenging and fun at the same time. But in March, all non-essential persons in the jail were directed to work remotely from home. So that included myself along with the program coordinator assistant. Because the jail was already using an electronic management system, the communication between staff and inmates, there was no gap. It transitioned fairly smoothly. So I communicate with the inmates, and it's very similar to email. It's called the kiosk system. So they will send me a message, and then I'll screen them and put them into whatever program is appropriate. I was able to do that remotely from home, as well as the program coordinator assistant. So programs or on-site programs were canceled, but we were still doing resource connection remotely. I came back on-site full-time to the jail in June, and we had first started connecting inmates to their providers. So when the pandemic hit in March, I was the liaison. Providers were coming through me, and then I'm speaking with the inmates, and then so vice versa. In June, we set them up with video visitation. there was a HIPAA issue with that at first because the inmates were still in their housing unit using the phone in earshot of their roommates. So we were only able to do case management system. When I came full-time back to the jail in June, we then developed a virtual program schedule that was compliant with HIPAA, and the difference is we would bring the inmates to a private room so that they could be alone, and then they could then discuss protected personal information. That allowed us to bring back the treatment counseling, the mental health counseling, any assessments needed to get people into inpatient treatment centers. And then the picture on the right is a person who just got connected to an inpatient treatment center last week, and she will be going there directly upon release. What's next? So I need to redesign and rethink how we can do group programming safely within the jail. I don't have a solution for that yet, but I hope to have that soon. And an identified problem came is that we're limited for space in the jail for programming because prior to the pandemic, that 50 hours of programming we were operating each week, we were using 4 different spaces in the jail. Well, now all the courts have gone to virtual hearings and sometimes, well, they're bringing back jury trial on site at the courthouse. But anywho, so those 3 spaces are now being used for the court. So we went for 4 spaces for programming, operating Monday through Sunday at all hours to 1 classroom. So we're just going to rethink how we do that. I think that we're looking at refocusing the programs to be more heavily in the reentry and following them upon release and then getting them more connected. But those are my 2 challenges that I will work through. So this is my contact information, and I have a few minutes for any questions that you may have.
Well, first of all, I'd just like to thank you so much. It's just been a great pleasure to work with Cassie and the sheriff, and the progress, as you can see, that has been made under both the sheriff and Cassie is phenomenal. We did, Cassie and I and Diane Bricker from our corrections department did go down to Franklin County, and Franklin County was doing something similar on the pocket guide, except I don't remember, it wasn't like the little small one that we have, which I think is so important because you can just stick it in your pocket and carry it around, and so everybody has such a great reaction to that, and then the amount of information that's been put in that, and that because of the press release that went out, the news media has called, and the sheriff did a great interview on Channel 4 and about the pocket guide, and we've gotten other requests too from the media. But anyway, it's just phenomenal, the work that you've been doing. Thank you.
I don't know that I have anything to add. Commissioner Lewis does a good job keeping us updated from time to time on this, and I appreciate all of this being done, and obviously this is good work, and it's great for the people in our county that need help, and so thank you very much. And not just the 2 of you, but everybody that's involved in the program. Thank you.
Yeah, that, as mentioned before, the pocket guide is really clever, unique, just, and so helpful. It's one of those things that you just don't think about, but here's an easy way to help people re-enter much better than previously because it was so scattered and so on. So, yeah, so thank you for the leadership on that. I had a question for the sheriff. I know we reduced the jail population from 230 to 90, roughly. The governor tried to do that at the state level with the prison system, but I don't think he was able to reduce that much. I think it went down maybe 1,000 or something like that. What was the different approach?
Well, it's a different population. Obviously, most inmates that are housed at the county level, they're there for shorter periods of times. for a shorter period of time and for less serious offenses. So I think there's more latitude for the courts, the prosecutor, and probation to manage that population. I mean, once they're into the prison system, they're generally for more serious offenses and for greater lengths of time. And I do think, too, I continue to call it probation services, you know, but the ability to manage some of the population in your community that probably is greater locally. And again, that's a tribute to what we've done here in Delaware County and to leadership of our commissioners as well. So I think that's probably the short answer to that, Mr. Benton.
Okay. I thought it probably had something to do with the seriousness of the crimes, but still, it's remarkable that you got the courts and the prosecutor,
Those numbers are starting to go back up now,
Probation.
and there was the whole world slowed down, and the courts and law enforcement even slowed down remarkably during that period of time. But now those cases are starting to come back. Sentences that were deferred, inmates are coming back for sentencing. So whether or not we'll see that 220 population anytime soon, I'm not quite sure of that yet. I think we're at about 150. Do you know what the count's been recently?
Today, we're at 178.
178,
Oh,
so it's starting to come back up.
Quite a bit
And,
back.
you know, Cassie, I'll conclude with this. The jail has come a long way in 8 years. It's really remarkable when I think about when I was first appointed and to where we are now. And it's a tribute to the leadership that we now have in the jail and the staff, including people like Cassie. They've just done a remarkable job out there. It's a high liability area for our entire county, and I've taken that very serious and try to put people and processes and policies and procedures in place to eliminate, to the best of our ability, some liability. And but that will continue, obviously. And Cassie alluded to space needed for programming. So as your population changed, when I came here, average daily rate for women was probably in the high teens, maybe low 20s. Now it's, over 40 perhaps. I mean, so we've seen an influx of women incarcerated, which requires changes in how you manage that population. So I will continue to come back to this board, unfortunately, with capital needs in the jail over time. I mean, I don't think we're going to need a new jail anytime soon. And just because we've got 276 bed spaces doesn't mean we have capital needs. So, you know, I do want to plant that seed, and I'll be judicious as I make those presentations to you as time goes on. But you've done a great job supporting this office, that part of my budget, and it's a tribute to what the people in leadership are doing out there now. I think it's, to be honest with you, I think we're the best jail in the state of Ohio. And that's a tribute to the people that work there. So thank you for your support. Any other questions?
No, thank you.
Thank you
Thanks
for coming.
the extra diligence at the jail and so far being successful in avoiding COVID cases. So
Yeah.
really helps a lot.
Thank you so much.
All right, Jennifer?
Wait for Mr. Stelter to come in. Resolution number 20-629, in the matter of approving a transfer of appropriations for the Sheriff's Office.
So moved.
Second?
Discussion? Any discussion?
Just a couple
Nope,
administrative
need to introduce
transfers.
yourself.
Oh, Dean Stelzer, Chief Business Officer for the Sheriff's Department.
Yeah, thank you.
These two are just moving funds for projects that were already appropriated. The one's a training piece of equipment that they're going to use for firearm simulation. It was intended to purchase it originally, so it was budgeted out of the capital account, and now they're going to lease it on an annual basis. That way they can get all the upgrades and keep it more current, more relative. It's coming out of special fund. State had designated money for law enforcement training, and the money was appropriate. It's just moving it to a different account. The other item is there was a cruiser that was in an accident last year and was totaled, and there were insurance proceeds, but the Sheriff's Department has to pick up the difference between what the insurance pays, and there were no funds appropriated out of the capital account in 2020, so it just shifts from a different account into that capital account.
Okay. Vote.
Vote on motion 20-629. Mr. Benton?
Aye.
Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Resolution number 20-630, in the matter of accepting the subgrant award of the Leap Forward Grant for the Sheriff's Office.
So moved.
Second?
Discussion?
This grant and the next are both associated with the Drug Task Force. The LEAP portion has been an annual amount that has come in for the last several years. The $50,000 was an additional amount that was allocated actually last year, but they just got the paperwork through this year from Recovery Ohio program. Both of them will go towards activities of the Drug Task Force.
These dollars were budgeted.
The $50,000 was not. I don't think last year at budget time they were aware they were going to get it. I will be coming back to appropriate those funds once they determine exactly what they want to use them for.
Okay. All right, vote.
Vote on motion 20-630. Mr. Merrill?
Aye.
Mr. Benton?
Aye.
Mrs. Lewis?
Aye.
Resolution number 20-631, in the matter of accepting the Recovery Ohio Subgrant Award of the Leap Forward Grant for the Sheriff's Office.
So moved.
Second.
Discussion? Any further discussion? You mentioned it in your previous remarks, so, okay. Vote.
Vote on motion 20-631. Mrs. Lewis?
Aye.
Mr. Benton?
Aye.
Mr. Merrill?
Aye.
I think that's it.
Thank
Thanks,
you,
Dean.
Dean.
Resolution number 20-632, in the matter of approving a memorandum of understanding between the Delaware County Board of Commissioners, the Delaware County Department of Environmental Services, and American Federation of State, County, and Municipal Employees, Local 2896, Ohio Council 8, AFL-CIO.
So moved.
Second.
Discussion?
Morning, Commissioners. Tiffany Mag, Director of Environmental Services. So this is an MOU for a few supplements that we're adding for our operations staff. The first one is for our regional wastewater operators. They're now able to receive a Lab 2 supplement, which is 90 cents. And then our relief operators are able to receive that same Lab 2 supplement for 90 cents, as well as a wastewater 1 supplement for 35 cents, or a wastewater 2 supplement for 65 cents.
Okay, vote.
Vote on motion 20-632. Mr. Benton?
Aye.
Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Resolution number 20-633, in the matter of approving the sanitary sewer subdividers agreements for Meadows at Home Road, Homestead at Scioto Reserve Sanitary Sewer Connection, North Lake Woods Section 2, and Villas at Old Harbor East.
So moved.
Second.
Discussion?
So the first one, the Meadows at Home Road, this is a gravity sewer connection that'll take a pump station offline. This is at the corner of, just south of Home Road between Stites and Riverside Drive. And then the second one, North Lake Woods, this is 47 single-family homes, which is located off of Four Winds Drive near 71. And then the third one, the Villas at Old Harbor East. This is 52 lots, which is off of South Old State Road, just north of Hollenbeck Road. All three of these are just standard subdividers agreements.
Okay, vote.
Vote on motion 20-633. Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Mr. Benton?
Aye.
We are on page 392.
Thank you.
Resolution number 20-634. Resolution of necessity for the purchase or lease of a motor vehicle for the use of Delaware County Regional Sewer District.
So moved.
Second.
Discussion?
This dump truck is something that we're looking to replace an existing dump truck that we have. It's a 1995 with over 300,000 miles on it. It actually has a shorter dump bed on the back because we got it from the county engineer's office. And we need something with a higher dump bed and something that's in obviously better shape. We budgeted $120,000 for the truck this year, and this one is just a little over $114,000.
We will be taking this one out of service,
The old one will be taken out of service, yes.
because I always worry about they don't go out of service and, leads to,
Correct, yes.
Okay, vote.
Vote on motion 20-634. Mrs. Lewis?
Aye.
Mr. Merrill?
aye.
Mr. Benton?
Aye.
Resolution number 20-635, in the matter of approving a service agreement with Mr. Built Incorporated for installation of rear push wall at the Delaware County Solid Waste Transfer Station.
So moved.
Second.
Discussion?
So these are walls that are going to be installed for us to be able to have a compactor on site. Rumpke is installing the compactor at their cost, but we need the push walls around the compactor basically to allow the trash to go into the compactor without falling over the sides. So we'll no longer have the tip floor. Everything will go into that compactor. The compactor will actually be taken into the new transfer station when that's built in a couple years. And then this wall, we would need these regardless to be able to do anything else with this site. So we would have been building them in the future anyways. So it seems to make a lot of sense. We'll get a lot of additional volume through the site, potentially up to double the volume that we currently get once we ramp up to that amount.
Okay, yeah, that was the question I had, was whether it would be usable in the new facility. or the
Yeah, so
remodeled
we won't be able
facility.
to have a tip floor there in the future, or else you'd have issues with things, dumping over the side. So no matter what, we need to have walls to be able to enclose it, to use it for hazardous waste drop-off or recycling, or whatever the case may be, as we kind of work through those negotiations with Rumpke. But no matter what, we would need these walls.
Okay. All right, vote?
Vote on motion 20-635. Mr. Benton?
Aye.
Mr. Merrill?
Aye.
Mrs. Lewis?
Aye. Thanks.
Ms. Bagwell, you're here. What about the status of the new transfer station? What's our progress on that?
So we had a meeting with Rumpke last week. What was that? Monday, I believe it was. So we talked through kind of where we're at with the negotiations. Right now, it's kind of in the attorneys back and forth. But we've looked at, I believe we're going to put it up on the front site near 42 instead of on the back piece of property, because I think I can't remember what the savings was, but it's significant savings to have it up on the front site. So right now, we're just kind of working through the legal terminology with the attorneys. I'm thinking within the next month or two, we'll have something we're moving forward with. So I think it was a good meeting. Everybody seems to be working in, really good coordination with each other. So we'll have you an update as soon as we have more information on that.
Okay,
Thank you.
very good. Thank you, Tiffany.
Resolution number 20-636, in the matter of approving ditch maintenance petitions and the ditch maintenance assessment for Woodcrest Crossing Section 1, retreat at Woodcrest and Genoa Place.
So moved.
Second.
Discussion.
Good morning, Rob Riley, Chief Deputy Engineer. We have two subdivisions. One is a 60-unit condominium development in Liberty Township, north of Hyatt's Road, and Genoa Place is a 4-lot common access drive subdivision off Worthington Road. This will place the drainage systems for both of those subdivisions on the county's program.
Okay, vote?
Vote on motion 20-636. Mr. Merrill?
Aye.
Mr. Benton?
Aye.
Mrs. Lewis?
Aye.
Resolution number 20-637, in the matter of approving right-of-way work permit summary sheet.
So moved.
Second.
Discussion?
3 utility permits, nothing out of the ordinary here.
Okay, vote?
Vote on motion 20-637. Mrs. Lewis?
Aye.
Mr. Benton?
Aye.
Mr. Merrill?
Aye.
Resolution number 20-638, in the matter of approving a contract of sale and purchase between Steve T. Long and Deborah A. Long and the Board of Delaware County Commissioners for Dell CR 124-6.45.
So moved.
Second.
Discussion?
This is one of the parcels that is needed for the home road improvements between Perry Road and Route 23. We've negotiated a settlement with the owner and recommending your approval at this time.
Vote?
Vote on motion 20-638. Mr. Benton?
Aye.
Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Thank you.
Thanks, Rob.
Thank you.
Resolution number 20-639, in the matter of approving supplemental appropriations for the law library.
So move.
Hi, Julie Jones.
Oops, I'm sorry, hang on a second. You're not going to second? Okay, I'll second it. Discussion?
I'm sorry.
No,
Hi,
no problem.
Oh, no problem.
I'm Julie Jones, Administrator and Librarian of the Law Library. Just asking you to please approve supplemental appropriations to get us through continuing paying the full-time salary until you can meet with the board to discuss what we're going to do in the future.
Fewer tickets being issued during the,
There were, yes, but it's not reflected in any of the paperwork yet, but we just got another check from the city that's back up to normal, so I think
Okay.
people are out and about, and we're starting to get more
Okay.
tickets and back to our regular income, thankfully.
Yeah.
So it was only really two-ish months where it was down a lot, so.
okay.
My concern is a person was added without bringing it to us before, and you may recall, And then they came to us after the fact asking us for money, and I voted no at that time, and I've got to be consistent. The process they used and notifying us, I found unacceptable, and I've got to be consistent.
Yeah, I understand the board made a decision after doing the budget.
Yeah, I agree. I mean, I'll vote for it, but we need to present a long-term plan on how we're going to do this, so that we can understand whether it makes sense to continue with the spending stream that the board did after the budget without our approval, which is not the right way to do it. So,
Well, I think we had a work session scheduled, didn't we?
I think we're going
And then are we still going to have that? I know we had to postpone it, of course, with the pandemic.
Yeah, I think we have one scheduled and postponed it.
But this was all before the virus came up.
Uh-huh.
Basically, it
Yes,
was approved, additional person was added, and they came and asked for money
sure.
to
Yeah.
pay the salary that they didn't ask for before. And that's the reason I have a concern.
And the work session also was to discuss future plans of them moving locations and things like that.
Yeah.
yeah, and I'd like just to make sure we have a full review of why the position was necessary, the activity involved in hiring an additional person, again, without our sign-off. So, again, we need to understand that long-term how the law library is going to be managed, funded, et cetera. Because the world is changing. I mean, a lot of it is online, don't need the facilities, don't need the books that you used to need and so on, so. Okay. Further comments? Okay, vote.
Vote on motion 20-639. Mr. Benton?
Aye.
Mr. Merrill?
No.
Mrs. Lewis?
Aye.
Thank you. Yeah, the board is looking
Welcome.
forward to meeting with you guys.
Nice seeing you.
Thank you.
Resolution number 20-640, in the matter of designating Program Year 2018 Community Development Block Grant Allocation Grant Funds as Public Facility Fund to serve a low to moderate income, limited clientele, and authorizing the Delaware County Administrator to seek approval thereof from ODSA, and upon approval, complete the purchase in accordance with applicable laws and regulations.
So move.
Second.
Discussion.
Bob Lamb, Economic Development Director. Before you is a request to allocate CDBG funds for the acquisition of a 12-person van for the Ward 2 initiative. This van will be used to support their nonprofit activities such as youth-oriented programming as well as underserved population support. These funds are through this 2018 CDBG, and so they are required to be used or need to be returned to the federal government by the end of August. These were the funds that were originally being looked at for sanitary sewer improvements, but because we're unable to secure support in that area, we position them for this type of activity. This is through the same funding source that the rent assistance program was used to provide earlier this year due to COVID-19 issues. Happy to answer any other questions on this item. Thank you.
Just like to reinforce, the funds are to be used for youth organizations and servicing the youth in our county and other people in need.
Correct.
Right, yeah, good use of the funds that we would lose otherwise, and so good to see it put to good use for at-risk youth in our county, so.
So we allocated, as you said, like the 89,000.
39,000 in this case.
Right, I mean, in the past, we did, and is this the 39,000, is 39,000 being taken out of the 89, or this is in
No, this is in addition. We had approximately 140,000 of those dollars remaining.
Okay, thank you.
Now, do we know the van's going to cost 39 or just some portion of the 39?
No, we have been working with different providers for the van, and we have been able to secure a price right about at this point of the 39,000.
I've got to ask the obvious question. The van should be as much as needed to serve the purpose. We shouldn't buy more than we need just because the money's there.
So, yeah,
I'm stating the obvious, and I feel like I need to state.
the original ask was for around a 15-person van, and my understanding is that as we looked at what was currently available for the price point, 12-person van was what we were able to find, and they were very happy to have that to meet their needs, maybe not as much as they would have hoped, but definitely better than the current situation.
Very well, thank you.
Okay, thanks, Bob.
Thank you.
Vote?
Vote on motion 20-640. Mr. Merrill?
Aye.
Mrs. Lewis?
Aye.
Mr. Benton?
Aye.
Thank you.
Thank you.
Resolution number 20-641, in the matter of authorizing the use of Delaware County Safety Grant funds to purchase EMS ballistic vests for the Emergency Medical Services Department.
So moved.
Second.
Discussion.
Good morning, Dawn Houston, Deputy Administrator, and I'm requesting your approval of the next two resolutions. The Workers' Compensation Safety Grant Committee met a week or so ago to review the request of Emergency Medical Services to purchase ballistic vests for their part-time staff. Currently, the part-time staff do not have these vests that they need to utilize in on certain runs. And what we would do is purchase 3 vests for each of the medic stations in each of the 3 sizes that they come in. They wouldn't be a custom fit, but the medic could use the one that fits them the best. We also would be replacing outdated vests for the full-time staff. And the total cost would be $25,000 out of the Workers' Compensation Fund. And that would fund approximately 55 vests. So we're requesting your approval. If you have any questions, I'd be happy to answer them.
The purpose of the vests, again,
When they have runs where maybe there is a domestic or some sort of safety type situation, they would don the vests at that time if they needed to go in to assist a
Okay.
person that was hurt or a victim of
Okay.
some sort.
personal safety then? Yeah.
Yes,
Okay.
yes, exactly.
Okay, thank you.
Yeah, that's what Dr. Fischel filled me in on Friday, I think it was, that there are designated types of calls that they immediately put a vest on as they go out. So this would fit, this would add the part-timers to the vest list.
Correct, yes, because they currently don't have the vests available.
Okay,
All right, vote?
Vote on motion 20-641. Mr. Merrill?
Aye.
Mrs. Lewis?
aye.
Mr. Benton?
Aye.
Resolution number 20-642, in the matter of approving a supplemental appropriation.
So moved.
Second.
Discussion.
And this would just be appropriating the funds for the purchase of the vests.
All right, vote?
Vote on motion 20-642. Mrs. Lewis?
Aye.
Mr. Merrill?
Aye.
Mr. Benton?
Aye.
We do have an item for other business today, if the board would like to address that now. Resolution number 20-643, in the matter of changing the time of the Thursday, August 20th, 2020 Commissioner session from 9:30 a.m. to 9 p.m.
So moved.
Second.
Discussion. If anybody wants to mention it, we just need to move it up because we're going
Yeah.
to have an executive session on healthcare that day, so. We'll take a vote.
Vote on motion 20-643. Mr. Merrill?
Aye.
Mr. Benton?
Aye.
Mrs. Lewis?
Aye.
That brings us to administrator reports.
Good morning, Commissioners. Mike Fromer, County Administrator. The main thing under Administrator reports today is an update. Sheila Hiddleston, our Health Commissioner, is here today. And I asked in meeting with her last week that she come in and update you guys on the indicators and some of the status of things. So we're going to have to probably juggle the room around so we can keep under the 10. So.
Welcome.
Yeah, I think we can.
I think we have to subtract one.
Thanks, Sarah.
For me, leave?
Sarah, you're gonna, okay.
Point it there. Okay. Oh, I was trying to figure out where it was. 1, 2, 3. 5, 6, 7, 8, 9. Oh, yeah. Okay.
All right.
Morning, Commissioner Sheila Hiddleston.
Yeah,
your mask
yeah,
off,
you can
really
take your, yeah, because we have trouble hearing when,
Recording it,
Okay.
yeah, we're on audio.
yeah.
Good morning, Commissioner. Sheila Hiddleston, your Health Commissioner. Administrator Mike Fromer asked me to come down and talk just a little bit about COVID-19, what's going on with the numbers, what's going on with the risk levels, what we're hearing on the street, maybe some of the concerns that we have. And so I brought with me Adam Howard. Adam is normally our Director of Preventative Health, and during our incident command structure, he's our operations chief. And so for those of you that aren't real familiar with incident command, that's the group that actually implements all of the plans. And so he is in charge of our epidemiological team or epidemic response team. So that's kind of where most of the action is working, at least with the individuals. We also have several staff that are working with the businesses and the communities and the schools and, you know, giving guidance, putting together best practices. That's not under him directly, although technically it probably should be, but it's not. And then just kind of just a big picture. So obviously you all know what's going on. At the Health District, we've been in incident command for since January the 30th, so coming up on 6 months. It's hard to believe in some respects. In other respects, it seems like we've been in incident command for forever. We have about 75 staff, and all but about 15 of them are probably devoting at least 80% of their time to this. We have been open 7 days a week. Well, we're not open to the public 7 days a week, but we've been working 7 days a week from 7 a.m. to 7:30 p.m. since about the middle of March in order just to keep up with all of the work that needs to happen. So we're going to talk first kind of about the numbers and what that looks like for Delaware County, and then we're going to go in and talk a little bit more about the risk levels and then have some time for some conversation about what does that look like and what are you hearing and what kinds of concerns that you have. So I'm going to actually turn it over to Adam because he's going to go over the numbers. It is his team that, I'm going to write this down for you. It is his team that actually takes care of the numbers. The only thing I do want to add about the numbers, and when you are listening to people talk, a lot of times they say, well, the numbers don't mean anything. The numbers don't mean anything. They're just lies. This is what I will tell you. The numbers in Delaware County that we put out, 100%, I would bet my life on those. So I can't address some of the numbers that other people are putting out there, and I'm going to talk a little bit in some of the numbers that the state puts out there, but I can tell you 100%. I would bet my life on them. So, Adam, I'm going to, I guess that's all nice and clean for you.
All right, well, thank you for having us. We'll get right into it. So first we'll talk a little bit about some of the definitions before we get into the numbers. So we have different, if you follow us on Facebook or you pay attention to our website page, we have different classifications. So confirmed means the person meets all the clinical criteria and then they go and get a test. And that test comes back. It's a diagnostic test. Usually it's that swab. It kind of goes back in your nose. It feels like it tickles your brain a little bit. And then it comes back with SARS-CoV-2 on it, which tells us the person has COVID-19. So that's a confirmed case. They've been tested and we can prove it with a test that they have the disease. A probable case is they have all the same clinical criteria. They have a link to a confirmed case, but they don't have that testing. So the only thing you're missing is the testing. Our total, we just combine them together. This is a typical, this is typically how we count infectious disease. We add probable and confirms together. Recovered are the folks that are coming out of isolation. So our probable or our confirmed cases that are coming out of isolation. And we know they come out of isolation because we keep regular contact with them. We try to call folks every single day, but we let them kind of tell us, well, every day is a little bit too much. Maybe you should call me every other day. Or maybe on Monday and Friday. So the communication there is to both make sure that they're doing better, that their symptoms are doing okay, and to see if they need anything. I've went out late at night and picked up baby formula because they needed formula for their baby and they couldn't leave their house. So it's not just checking on their symptoms, it's checking to see what else they need. And active cases are just those folks that are still under isolation, those folks that are still recovering. We'll move on. So currently isolated and quarantined, and you'll see this on our infographic that we put out there. And these are both the cases, both those probable and those confirmed cases that are under isolation, as well as the contacts. And to be a contact, it isn't just casual contact. It's you're within 6 feet of the person for 15 minutes or more. So all of those people go under a quarantine. It's basically a watch period to see if they develop any symptoms. Quarantines are based on how long it takes to develop a disease. For COVID-19, it takes up to 14 days, so that's why the quarantine there is for 14 days. The isolation is a little bit different. Isolation is based on how long it takes you to get better. It usually takes about 10 days to get better, so that's why isolation and quarantine have different time frames on them. And then again, as I said, we provide any kind of resources that they need. We're there to provide food. We're there to provide the baby formula. We've provided a lot of thermometers, medications. We're basically your DoorDash and your Grubhub and all that combined for these folks that are under isolation quarantine because we want to make sure we make it easy on them. If we tell you to stay home, but you really need food and you don't have any, we're not making it easy for you to stay home. So it's not just our job to, just tell you to go stay home. It's our job to make it easy on you. Completed isolation and quarantine, again, these are folks that have been released from isolation and quarantine. Again, we know this because we're in regular contact with them. We issue letters releasing them from isolation and quarantine. That way they can use it if they need to go back to work and if their work requires any kind of notification that they're okay to return. So a contact, it's not just casual contact. So you and I walking down the street and passing each other, that's not really a contact. We're going to need to spend some time together. We're going to need to be close enough to each other. I'm standing here and I'm well over 6 feet away from any of you, so we're not really contacts right now. Now, if I approach the bench there, we're within 6 feet and I'm there for 15 minutes talking to you, now there's more of that potential of me talking and droplets coming out of my mouth, so then you're going to become a contact at that point. A contact is a little bit different, though, because you can also be a contact for a shorter amount of time if something unusual happens. So say we're talking face-to-face and one of us sneezes on the other person. Well, now we don't really need that 15 minutes because we've actively put those droplets in each other's face. So a contact changes a little bit there. Households usually are always contacts because the reality of separating yourself from everyone else in your house really just isn't there. Some folks can do it. Some folks have a separate doorway into their master. They're able to keep all their trash and their dishes in their master. They have a shower, and we work with folks on that. But generally speaking, most of us can't really do that in our houses. So households are usually contacts. So I want to talk about a little bit about what some common misconceptions that we hear. So the number one misconception is probably probable cases. And what is a probable case? Why do you use a probable case? So probable cases are used in a lot of different infectious diseases. It's basically, as I said earlier, you meet everything else. You meet all those clinical criteria, and you've been exposed to someone. So I don't just have the symptoms. I also worked with someone who had a diagnosis of COVID-19. So now I not only have symptoms, but I have an exposure as well. So when you put those two things combined, we don't really need the test to tell us that you've probably got COVID-19. So we use this in a lot of different scenarios. Another reason that you wouldn't test a probable is will it change anything? So if we have a probable and there's no change in treatment, then what is the benefit of actually getting that probable person tested? Not really much because we're not changing treatment. But what are the risks of getting that person tested? So if you're probable and I tell you to go to your healthcare provider, now I'm exposing everyone that's in that waiting room. I'm exposing all those healthcare providers. So it's a risk there to get the person tested with not much reward unless those symptoms get severe, all right? So if you're at home with a fever and a cough, there's not really much reason to go get tested at that point. So you'd probably stay a probable throughout your entire course of illness. The other thing with probable cases is we get a question on are they duplicated? So if a person's a probable and then they get tested, are they now counted in the probable and the confirmed? And that's no. Every case that we report is only counted once. And I know that because we look at the data. We know the names of the people, the address of the people, the phone numbers of the people. So I know for a fact that these cases are one individual person. You could get tested 5 times, and some people do, and that's still only one case. So I want to point that out, that there's a big difference between number of cases and number of tests. And we don't report number of tests because that doesn't really tell us anything. We're just looking at the cases. The other thing I want to talk about is hospitalizations. Sometimes it gets confusing. I know I've heard that if you go for ankle surgery and you test positive for COVID-19, you're going to be counted as a COVID-19 hospitalization. And I can tell you that is not true in Delaware, all right? If you are in the hospital because you needed ankle surgery, we're not going to list you as a COVID-19 hospitalization because that doesn't make any sense. We are only looking at those folks who are severe enough in the illness from COVID-19 factors that get hospitalized to count as a hospitalization. So our hospitalizations are only those folks who are having severe symptoms from COVID-19. Deaths. So for deaths, we look at each death individually to see what it is because it's a serious thing. And we look to see what caused that death. So if, heaven forbid, someone is driving their car and they get into a car accident and they die in that car accident and they were also positive for COVID-19, that is not a COVID-19 death. That is a car accident. So we look at each one of those individually, and I can tell you that because we review each one of them. I know that we've had folks that have died that we were tracking that were not related to COVID-19, and that's how I know that our deaths do represent COVID-19 deaths. The other thing is just, communicable disease. So I just want to tell you guys, this isn't new to us. Communicable disease investigations are something we do every year. Last year we did over 1,400 communicable disease investigations. This is what we do. This is what we know how to do. Isolation and quarantine, that's not new either. Last year we probably had, 3 or 4 people who were put under isolation in their home, but nobody knows about it. Because we protect those folks' privacy as much as we can. So this isolation and quarantine isn't new. We know how to do it, and you all actually probably know it as well because a lot of times we do it with tuberculosis, and we have a partnership together where we treat all our tuberculosis cases in the county. So it's not something new. It's something that we've been doing for a long time. And the last thing I just want to talk about was real-time data. So throughout this entire response, we've tried to weigh how much information do you put out there, how much is too much information, and how do we account for when things change? Because as we're doing investigations, things change. I can tell you on our southern borders, on our southern borders with Franklin County and Columbus Public Health, even between the 3 of us, we have to get on the phone and say, okay, this person's address is on Taylor Way. Is that still Delaware County or is that now Westerville? I don't know, because annexations continue to happen in that southern area. So when those things happen, we transfer. But if I transfer it out of our jurisdiction, then it cuts off of our numbers and it goes into that other jurisdiction's numbers. So they're not getting counted twice there either. But that's kind of the pitfall with real-time data. We want folks to know what's going on, but you have to bear with us when things change and it doesn't quite look like it adds up. It's because things do change. Okay, so this is kind of what we were talking about with the numbers. So our confirmed cases plus our probable cases is how we come up with those total cases. And again, confirmed is basically the tested. Probable is you have a link and you have all of the symptoms. The recovered, again, are the folks that have come out of isolation, both our probable and our confirmed cases who have come out of isolation. Total deaths, pretty self-explanatory. Our probable and confirmed cases that have died, and that's how we come up with our active cases. Currently in isolation is going to look higher because, again, that counts both cases and contacts who are under isolation and quarantine, and completed is just those folks that have come out of there. Currently hospitalized and total hospitalized, these are our residents no matter where they're hospitalized. So if they're hospitalized in Franklin County or Cincinnati, they're still our residents, so they still get counted in our numbers. And again, deaths are those folks who have died related to COVID-19. With that, I think I pass it back off to...
And can I ask you a quick question?
Yes, sir.
One, I feel good about Delaware County and how they do it, but I can't say I believe that's true all over the country. I don't believe that is true all over the country. The example you gave about, let's say somebody's in Riverside, and they reside in Delaware County, we would count them.
Correct.
But how do we know that Franklin County's not also counting them?
Okay, very good question. So in Ohio, there's a statewide data system. It's called Ohio Disease Reporting System, ODRS. And so all of the cases actually go into that system, and in there, we transfer the jurisdiction. So if we notice that Franklin County has one that's our jurisdiction, we say, hey, Franklin County, you need to transfer that one over to us. And likewise, they do the same. So it's a statewide system that we all play in, we all work in. So that's how there shouldn't be any kind of duplication.
Shouldn't be is not 100%. So there is the potential
So
for misinformation in some of those situations.
There's a small potential, and what usually happens is sometimes a person may get added twice. So the lab might have entered the person once, and then a health district added the person once. But we catch that stuff when we start doing the workup on them, and when we start, especially when we start talking about did the person die. So we're all working under this common system. So we're looking at the person up by name and date of birth. So we see that, okay, there's 2 Adam Howards with the same date of birth. Something's wrong here. So there might be a small amount of time where there's a misrepresentation, but we find those, and then we eliminate, obviously, the one when we find it.
I'm not questioning us. I'm questioning whether Franklin County would provide the same level of scrutiny that we're providing.
I can't speak to exactly what they do, but I know that they're doing their best down there as well, and we work with them a lot. Obviously, I don't know what their numbers look like because I don't deal with them on a day-to-day basis, but I can say with not 100% accuracy, but it should be pretty darn accurate considering we're all working out of the same state system.
Thank you.
No, I did not.
You'd think after 6 months, we were used to the social distancing dance. That's what they call it. Commissioner Merrill, I want to go back to your question. The ODRS system is not new for COVID. We've been using this system, gosh, it's been at least 15 years. When you go into that system, if you try to enter somebody a second time, from our perspective now, the lab, we're the ones who are accountable for if it gets entered in there twice. It alerts you that there's another person. And actually, not only are we looking at that data every day, but at the end of every day, the Ohio Department of Health also goes through that data, and we know that because every time somebody goes in there and enters anything, it tracks all of us, and they change things all the time. They'll say, duplicate case noted. So I won't bet my life on that one, but I'd pretty much bet almost my whole life on that one because the system, it's not new. If this were a brand new system that we had never worked in, I would think that there would be more likely that we would have errors. The other thing that went into place several years ago is one of the quality indicators under, I think it was under CASIC. We actually are evaluated on our ability to utilize the ODRS system appropriately, to have all of the data entered into it, and we do not get our quality indicator if we don't meet all of those various criteria, and every local health district in the state, 113, are all evaluated on there, and if you went back and looked at the last time that they did this data, which would have been for 2018, very few health districts don't always meet that one because it's something that all communicable disease people take very, very seriously. So again, I can't bet my life on that, but I would tell you there's very little error in that system. So let's talk about the risk-based, I'm sorry.
Could I just ask one question? I was curious as to how, when someone is tested then positive for COVID, how do you then determine, do you ask them, like, have you traveled, or where did you stay, and all those, to find the source, I guess?
Well, you don't ever definitely find the source unless there's an epi link. You can find the source if it's obviously another person. But we have, I think right now, the interview is probably, I would say, about 12 pages long.
Oh, okay.
Yeah, so the interview that we do with each case, I just did case investigations last Sunday, not yesterday, a week ago Sunday, and it probably takes almost 2 hours to
Oh my
complete an
gosh,
investigation, just the case. That's not all the contacts, that's just the actual case, because it's about a 12-page. We do ask, where have you been, who have you come in contact with? We've added a newer question about large gatherings, and I'm going to talk about that in a minute.
Okay.
But yeah, we ask all of those questions to try to figure out if we can tell. The other reason, though, that we do that is because we want to, if there are links, and this comes into play with the state system, if there are links, yes, the number is still a number, but it might be more easily explained than just if it's community spread. So we do ask all of those questions.
And then is that information shared, such as, because like you're saying, I mean, you go through a person's, where have they been, where have they stayed, but then it would be hard to pinpoint, well, gee, where did they actually get it? Unless then, like, if there's a common database, so someone then from another county would come down with COVID and, oh, they stayed here. Is that cross-checking available? Or? So
yes, if we have an outbreak, we have the ability to put it into the health alert system for the state of Ohio, and we get those 24/7, 365 days a year. If one health district is investigating a pretty huge outbreak of more of a public arena, not like in a nursing home, because we would be the only ones, but in a public arena, I'm trying to think, well, let's take the jail up in Marion County. When that one was first evolving, we got health alerts that said, this is what's going on, please be aware if da-da-da-da-da, this is probably epi-linked, and then we all worked together on those. We got one last week from, I can't remember where it was from. I don't remember. Anyway, we got one last week that one of our regional health districts was investigating an outbreak that had, they believed a lot of them were epi-linked, just to let us know that when we do that history, if that comes up, then we know it's linked. And within the odor system, there is a way to link cases together.
Okay, thank you.
You're welcome. Other questions? All right, so the state system, so again, I can take our data to the bank, but I'm going to talk a little bit about the state system. So risk-based systems are not brand new either. This is not something that has never been thought of before, and many states now are using a risk-based system in order to evaluate all of the data, because otherwise the data is just a bunch of different points, and we do need something to kind of bring those together. Now, the 7 points that we have in our system, and there are 3 more that they're beginning to collect data on, those were decided upon by the state of Ohio, but not necessarily did we make those up. The Ohio Department of Health, the Association of Ohio Health Commissioners, worked really, really closely with the governor's office to determine and to define what each of these were going to be, and then to define what data sources these were going to be pulled for. So the first 3, which is what put us into the orange a few weeks ago, all of those data points, we actually have the data for. And so again, I can take that to the bank, I know that they're valid, and I'm going to go through each of those. The remainders of those are not data sets that we currently have access to, although we have been told by August the 1st, we will have access to that at the county level. What happens is a lot of those data sets come into the state system, and you'd think, well, why would that be hard? Let's just run the Delaware addresses and pull them out. But it's not that easy, because like Adam said, in the state of Ohio, and again, I don't know what they do in other states, but all of our cases of any communicable disease are counted or taken care of by the health jurisdiction, regardless of where they are. And so let's look at the positivity rate, because that's something everybody always wants to talk about. The state is giving you the positivity rate for Ohio. The health commissioners keep saying, I need that county data. That's what everybody wants to know is, well, what's our positivity rate? They are getting all of the laboratory data from all of the labs, private and public, throughout the whole state. So it goes into the state system, so they have their denominator. We don't have our denominator. We only know how many positives because it's a Class A reportable, but that only means that you have to tell me the positives. So I never know the denominator. So we keep saying, I need to know the denominator for Delaware County. The issue becomes, if you were to say you were shopping over in Marysville and you ran over there and you got a test, yeah, the test is going to show up, but there's some filtering that has to be done to figure out that you really do belong to me, even though you had it done. So that's what they're working right now on, is those filters, so that I'll be able to get that data just for our residents. So the other ones I wanted to point out, just when you look at this overall, sorry about that, is that some of these are also done on a regional. So when we look at ICU admissions and hospital admissions, ER visits, those are based on us as a region. They're not looking at that just at Delaware County. And I'll use an example of Grady right now. So this morning, you may or may not know, Grady has 6 ICU beds, and this morning, all of those beds are full. Now, are they all full with COVID? Probably not. I mean, I don't have that data in front of me, but probably not. But if we only went by us, then we would have already flipped that next one, which is number 7, intensive care bed occupancy. Obviously, especially when you have a smaller hospital like ours is, that number might always stay. Because what they're looking at there is, do we have the capability to take any more patients on? And so we really need to watch that. So that is better that we look at that at a regional level. Does it make it a little bit harder? Sure, it does make it a little harder, because if you did have, say, one area that all of a sudden had a huge influx, could that affect us? It could, but in our region, we have 698 adult ICU beds in our region. And so when you think about that huge number and then the actual number that are there, that is not going to fluctuate as rapidly as if we were looking at one hospital every single time. This morning, there were 169 of those beds were occupied, so plenty of ICU beds out there. So you all know we went to red, and I think everybody was like, oh my gosh, we went to red, we went to red. But if you look at the difference between level 2 and level 3, the orange and the red, there's really not anything more, other now we all have the mask mandate, but it didn't all of a sudden say, oh my gosh, things are horrible. It really is to alert everyone that things are on the increase. We're not really where we were. We're not staying steady. We're not going down. We're actually on the increase. And I think Tracy Whitaker, who a lot of you all know, our PIO, she said it best. When the sheriff changes our snow level from 1, 2, 3, right, those are 1, 2, 3. 1, 2, 3, everybody doesn't panic when we get to 3. They just know, hey, maybe I have it backwards. Whichever one's the worst. I have COVID of the brain.
Yeah, it'll get better.
COVID of the brain.
I think it is.
Yeah, 3.
Yeah, you're right.
So
yeah.
everybody doesn't panic and think, oh my gosh, it's going to snow 20 inches today. They think, oh, okay, let me stop and let me think about what is it that I really need to do. And that's really what we want people to do with the red, is to stop and think, oh, in Delaware County, we're seeing an increase in cases. So if I don't need to go do what I thought I was going to do today, maybe I need to not do it. Before the mask mandate, put the mask back on. I was telling Councilwoman Keller this morning that I'm kind of to the point right now where I am really concerned about the masks, and I'm going to talk about those in a minute. But those people that are on the far end that are never going to wear one, no matter what I tell them, no matter what science is out there, who are never going to wear one, there's nothing I can do to convince them. The people on the other end that have been wearing them 100% of the time and probably not traveling as much and probably staying at home, maybe because either they're vulnerable or one of their loved ones are, I don't really need to worry about them. They're already doing it. What I think that we as a health district and as a state really need to work on are those people in the middle that back, if you think about it and think about your own experiences and where you were, when we first started opening things up, everywhere you went, people had masks on, and very rarely did you see anybody without a mask on. About 4 weeks ago, very rarely did you see anybody with a mask on. And so I really want to focus on those people who maybe they do or don't believe in them, but they're willing to wear them because it's not If it doesn't hurt them, I did get in trouble at the council. A person on Facebook said I said it couldn't hurt you. It could hurt you to wear a mask if you medically cannot wear a mask. But for most of us, we can wear a mask, and it's not going to hurt us physically to wear one. And so those are the folks I think that we really need to focus on. And in going from the orange to the red, that's what it is. It's an alert. Hey, there's more activity. Let's stop and think, what can I do to protect myself and my sphere of influence to try to stop the spread just a little bit. So this is where we are. We are in the red. The first indicator, this is one that we have the data for, 100%. That's our active cases by date. And so the definition is 50 cases per 100,000. And in Delaware County, of course, we have 209,000 people. That would be 100. And you can very clearly see, does this have a little pointer on it? Looky there. You can very clearly see right here in the early part of June, our lowest day was 43. Today, well, this is from Friday, but today we're at 242. So it has clearly risen 200 in the last little bit. So this one, very easy to see. This is just for Delaware County. This is actually our data that I'm showing you here. So it's very clear to be able to see that that has definitely gone up. The other thing,
Question. Cases would include testing, right?
positive.
Okay, so you go back to the earlier days, we were not testing as much as we are now. So of course you're going to have a bigger number now. So again, one of the concerns I have, and a lot of people who communicate with us, is it's not apples and apples.
Well,
and so it's very possible if you'd have tested the same number of people 3 months ago as you're testing now, that number would be up there too.
so that's where the positivity rate comes into play. These are the total number of active cases. Now, you're right, if I only test one person, then I only have one person to look at. But that's where you have to look at all these pieces of data and not just one data point. Because what you're talking about is the positivity rate, the number of tests that were actually done and the number that are positive. You also have to be careful with positivity rate, because in the beginning, we only tested people that were in the hospital, pretty much. So we almost had 100% positivity because we weren't testing everyone. Back here, in this period of time right here, our positivity rate for the state of Ohio was at about 3. Again, looking at the total number and the actives, the last time I looked at the state, it was up to 6. So again, it is, when you look at that, you do look at the total number of people tested. Now, do you still have to have a doctor's order to be tested? No. Do you still have to have symptoms to be tested? No. You do if you want us to do it, because that's the way that our testing that we have works. But in the gosh, let me step back. In general, anybody who wants a test right now can go and get a test. But you have to look at the positivity rate. So you can't just look at the number of active cases, but what we're looking at for this one is, it's that new case and that new rise. Does that make sense?
No.
I don't think you're answering Commissioner Merrill's question.
No, it's not. Go ahead. You give it a shot.
Well, let me make sure I understand the graph. Is that the number of active cases on that date, or is that the number of new active cases?
That is the number of cases on that day.
Okay, so in May, we were running roughly 50, let's
Right,
say.
about 50.
And now we're at 240.
242 today.
Okay. So I think what Commissioner Merrill is saying, let me see if I understand, and I think I agree. Back in May, how many tests were we doing, not positivity rate, how many tests were we actually doing the first week of May, and how many tests are we doing third week of July?
That is exactly what the positivity rate is. It does look at the number of tests that are being done. I can't tell you how many tests for Delaware residents. They tell me August the 1st, I will know that.
They tell you what now?
That I will on August the 1st. They have told us that the filtering in the state data system is going to work, so I will know out of my 242, well, not 242. Let's talk about, if what you're talking about would be how many new cases I get every day based on how many new tests are run. So that, I would know that in August 2nd, theoretically, if everything works the way it's going to, I will be able to pull up and see how many tests were done in Delaware County on tomorrow, the 27th, 28th. And then I'll get those test results. Usually they lag about 48 hours. Then I'm going to be able to look and I'm going to say, okay, well, in Delaware County today, I have 20 new cases. And on 2 days ago, theoretically, 40 cases, so that would be 50%. 50% of the testing that was done was positive. But I don't have that number right now.
I still don't think you're answering the question.
Well, the state data is a good example. If it was positivity rating of 3%, did you say back in May?
Yeah,
And now we're at 6.
right, so it has doubled.
If you have 100 people get tested, back then 3 had it, and now 6 had it. So the positivity rate, if that's on the up, if it's consistent, that means there's just more testing and not more people getting it. If the positivity rate doubles, that means it is spreading, maybe not as exponentially. I mean, there's some states that are, what, 15%?
Yeah, the governor's travel advisory is in place. If anybody has a positivity rate of 15% or more, they have to self-quarantine when they come in. That's a good way, though, to look at it. If it's staying the same, that means it's the same percentage of people are positive regardless of the number of tests.
But the methodology for testing has changed in the last 3 months. Those parameters are different, so it's not apples and apples. That's the thing that's frustrating a lot of people. The parameters in which we tested 3 months ago are different than the parameters we're testing now. So it's not an apples and apples comparison, and it makes it very difficult for people to trust the numbers.
But the positivity rate is apples to apples.
If someone did not show symptoms 3 months ago, if they were tested, they would have counted. But they did not get tested because they weren't showing symptoms.
Okay?
So my point is, the parameters in which we tested 3 months ago are different than the parameters in which we're testing now. So it's not apples and apples comparison.
But can we agree, I hear what you're saying, but can we agree that we have been using the exact same parameters for what we test since the beginning of July, and look at that curve? So our active cases, I'd have to go back and look and see exactly when they started doing the pop-up test. Do you remember? Okay, so we can go back and find that out. My pen's over there. You can help me remember that. We will go back and look to see when did they open up the testing, and then we can show you what our curve looks like.
I don't think you're going to get Commissioner Merrill's question answered, or mine, until we know how many tests were done every one of those days.
And on August the 1st, I have been told I will have that date.
That, I think, is the huge difference that we're not connecting on.
See, I think if you have the positivity rate, you can take those.
Yeah, I agree.
That's
Yeah.
the denominator.
Yeah, but
Right, that's the denominator that I don't have.
yes, but
Yeah.
even the positivity rate can change because people, like our son and daughter-in-law, got tested a couple weeks ago, and they turned out negative, but if they had turned out positive, they would have been asymptomatic, and they just decided to get tested.
So maybe this will help. Of all of our cases, 10% are asymptomatic. So 10% of the cases that came back positive of our data are asymptomatic, which means the rest of them are having symptoms, so even back before testing was opened, they would have all been eligible for testing. Does that help?
Yeah, I understand. That's what I'm saying. It's a factor that we just don't know what was going on 3 months ago and how many testing, how many asymptomatic, all those sorts of things are variables that drive the number of cases.
Well, and
The
again,
positivity rate.
that's one reason this is just one indicator, because you do have to be able to look at all of those. That's why we don't just pick one thing and say. We had someone, and we're going to talk about the R0 factor in a little bit. R0 is probably more important, much more important than positivity. We're going to talk about that one in a minute. Other questions about this one? I'm sorry, Commissioner Merrill. I hear what you're saying. All I can tell you is the data, the positivity rate, the fact that it's going up, and only 10% of our cases are asymptomatic, would show that there are more people in the community that have the disease. But we'll find out the date that they opened it up to everybody and go back and do a
Or
comparison.
there's more testing being done.
Yeah,
Which
we'll go back and look.
That's our point. There is definitely more testing being done.
Well, I think it's actually on the downside.
Well,
but-
maybe it is today, but versus March or April, it's way up. And we just don't know how
And there's a
much.
lot of people that just went out and got tested without this.
Yeah.
And we would tell you as your local health district, don't do that. It doesn't, there's no value in just going out. It doesn't tell you anything, because even if you get a negative test, it doesn't mean you're negative. It is just a point in time. I mean, there are states, there are sports teams that are testing every single person. Unless you test every single person every single day, that test does not tell you anything. It is not a screening test. It really, I mean, honestly, we've worked with several of our partners and encouraged them not to do that. It really doesn't help them. It doesn't, there are very little actionable data based on mass testing like that. Now, from an epi standpoint, which, you know, we're in public health, we love epi. We would love all 209,000 people in the county to be tested. That would give us, at a point in time, exactly what our positivity rate is, if we could do everybody. So from an epi standpoint, that would be great data. But when we're in the midst of an epidemic, we can't stop to do randomized studies related to that, although there are people out there doing those. We just can't. We love to do those kinds of studies, but we just don't have the staff right now to do that.
But if that means that you test all the Cleveland Indians players for COVID, and that means they can play baseball, then I'm all in favor of testing everybody.
Except,
Or the Buckeyes.
well,
That means that they can play.
I'm a Cardinals fan, so I don't really care about the Indians. But what I'm telling you is, and this is what I'm telling you, they all tested. It does not mean that none of them are positive. It also doesn't mean that none of them are infectious.
But it does mean they can play.
It does mean they can play, at least today, right?
Something I find very interesting about the data on the previous slide is if you take 100 tests from April or May, and the positivity rate is 3, and then you take 100 tests from the end of July, and it's about 6. In April or May, our criteria to test you was so strict, you had to have been showing signs and symptoms, a fever, stuff like that. Fast forward to where we are now, we have pop-up clinics, we'll test anybody. So now we have people that can get tested with 0 symptoms, and we're showing a positivity rate of roughly 6 per 100. And is it per 100?
It's just divided. It's just numerator and denominator.
And then before, it was at a 3 with a very, very strict testing parameter. I hear what you're saying with it's clearly spreading if we've gone from strict to not strict, and our positivity rating has increased.
That's what I was trying to say.
But we won't know, to the commissioner's point, until August 1st, we will not know how many tests have been done.
For our residents.
But you get that August 1st.
That's what they tell me, that the filters are all going to work. They're testing them now.
Will they, do you know, will you be able to provide the commissioners at that point how many tests were done in April, how many were done in May, how many were done, will they be able to see a rise and fall?
I would imagine, I don't know how far back, I don't know when they started requiring all the laboratories to report all of the tests regardless of whether they were negative or positive. So I don't know how far back we should be able to go, but I know the governor has been reporting positivity for at least the last month.
Okay, so the state has always had the data, they just never shared it with you. Okay. Yeah, 'cause from what I hear from, they're very interested in knowing those numbers, but you don't have them. But hopefully August 1st, you can give them exactly what they're looking for.
But what you said is very true, Chief. If it was 3 and we were barely testing and now everybody can get tested and it's 6, it's obviously we're having community spread.
Well, there again, I hear that, but maybe the people now, well, I've got a little bit of a fever, a little bit of cough, I'm gonna go get tested, they've got it. And that means there's more people with it, but they're handling it. There's no, because if you roll it forward, we only have 6 hospitalizations. And what was our hospitalization at the peak? 15, 20, somewhere in there?
15 or 16.
Yeah. So my point is, there are more people testing positive, but that may be because back then we weren't testing except as many people, and they're not rolling through because they aren't really sick. They may have a symptom or two.
Well, certainly that does tell us, and those are things that we talk to people about, is what symptoms did they have, how severe were they, are they getting better? I mean, I think your point, and I've got a slide here that's going to show our age group has changed to our highest age group is the 20 to...
another way.
Right,
of
so that's
saying
why,
it.
again, you can't look at one of these and say, let's hang our hat. I mean, thankfully, the state system didn't do that. I mean, honestly, let's look at all of these indicators and let it paint a picture. Let me compare it to just one quick thing, and then we'll move on, because I know you all don't want to be here all day. I always come and tell you when the health district is number one in the state for the Robert Wood Johnson ratings. By the way, we are again this year, although it completely got overshadowed by all of this. But we are, and in the midst of all of this, we also got reaccredited. So we're very proud of that. Someday we will celebrate that fact. But one of the things when the reporters call, they always want to know, well, aren't you proud of that? Isn't it the work you do? Well, first off, it's the work that all of us do together collectively to make us the healthiest county in the state, but it's also based on a bunch of different factors, some of which we do have complete control over, some of which that we don't. So I always tell the reporter it's one piece of the puzzle. And I think that's what we need to look at, not even just with the state system, but the other pieces of data that we have. We are seeing 10% of our people are asymptomatic. We have seen some decrease just recently in some of the numbers that I'm going to share you. And those are the things that we need to look at. I will also share with you that in some states, they are looking at these risk levels on a monthly basis instead of a weekly basis. That has been a discussion, an ongoing discussion between the Ohio Department of Health, the Association of Ohio Health Commissioners, and the governor's office about really how frequently do you look at this. You know, when we look at all of this data, we're looking at it as a snapshot in time. I mean, obviously, things are going to change, but it's just trying to give us the idea of, hey, we're headed in the wrong direction. Again, just like the snow levels. Okay, wake up, think about this. It's not gone away, which, I mean, quite frankly, personal opinion, although I think the data supports it, I think some of the reason we're seeing this increase is because people forgot. They saw our numbers were down to 33. They stopped thinking about it. Our hospitalizations, we had a couple days that it was 0. It's not a problem anymore. So let's start going out and doing things that maybe we weren't doing. Let's take those masks off. Let's go to the unofficial car show where there's over 100 people standing around and mingling. You know, all of those things people kind of forgot. And so now, with the risk levels, at least it's an awakening, I think, of people, hey, this hasn't really gone away. We do still have people dying. I mean, you want to talk about a great statistic. Death is never a great statistic, but we just had, I think, our last 2 deaths when we hadn't had a death in over a month and a half. So that's a good statistic. Again, the severity of illness, which we know is going to happen. In the very beginning, when we were having a lot of the outbreaks in the nursing homes, those people are much more vulnerable, of course, if they get something. It's what I tell you all every year about the flu. It's not that if any of us in this room, and I might be the oldest, it's not that any of us in the room want to get the flu, but if we get the flu, we're going to probably be sick for a couple days, and then everything will be back to normal. But our very, very young, our very, very old, and then those people in the middle, they're the ones that would likely die from it.
But people die from the flu, too.
Yes, they do.
So I could see people justifying the same kind of onerous steps for the flu next year. Just, yeah, I mean, there's probably somebody out there who will think of that.
There's probably somebody out there. I would tell you.
My point is, eliminating all risk is probably unlikely. So anyway, just an observation.
I think to think about, and maybe, I don't know if this helps, remember this is a novel virus that we didn't know very much about. And so you don't want, what if it had been worse? I mean, it's not been great, but let's say it had been worse and we hadn't put any steps into place to try to spread it, and then all of a sudden we were seeing a 100% mortality rate. So we're not, thankfully, but I think putting those steps into place to help us to figure out a little bit more about what's going on with the disease, and we find out something new every day. Just on the 17th, Adam talked to you about the isolation, and the isolation period is based on how long it takes you to recuperate and then no longer be infectious. So that's that 10 days. Up until the 17th of this month, the last 3 days of that had to be fever-free without any antipyretics, which are aspirin, Motrin, any of those types of medicines, Tylenol. They just changed it on the 17th to 24 hours because now we know more. As we've studied more of these cases, we know that as long as you haven't had a fever for the last 24 hours, it's much less likely that you would still be infectious. So if you think about the steps that were put into place, I mean, I'm not even going to go there. It really was to give some time to figure out, with the flu, we know how the flu reacts. We know who needs to get their flu vaccines. If the flu was brand new, or, you know, this isn't a flu pandemic, but in 1918, when there was the flu pandemic, they didn't know as much about the flu. So again, as things started to develop and people started to die, many places didn't put any steps into place. And if you look at their mortality versus the mortality rates of those cities that did, Dayton is a perfect example, and I think Pennsylvania, of cities that really put a lot of things in place, their mortality rates were much lower. So putting those steps into place was to give some time, quite honestly, was to buy some time.
Hey, Sheila, I thought we were running 150 to 180 cases, active cases, back in April. And the numbers there are obviously well below that. I could have sworn we were at 150.
Well, this only goes back to April the 14th.
Yeah.
So we'd have to go back a little further to see where we were in the beginning. These are the numbers we have now are our highest numbers. And I think the concerning thing is it's not that this is adding one every day. Every single morning that we come in, there are at least 20, if not more, in our queue waiting to be looked at. That's, I think, the concern.
Commissioner Benton, to your point, though, there's a rise in community spread, but like you were just saying, it's of a different age demographic now. And
Right.
luckily, it's of the healthier age demographic.
Exactly, and that's not, as the progression, it's not getting to hospitalizations. And
When we were first running these COVID cases around the county, and it was hitting the nursing homes, that's when we were seeing the heavy deaths. So the data there certainly explains the rise in cases, yet not the rise in hospitalizations or deaths, because it's hitting a healthier population at this point. To your point about the age group.
Right. I would bet a lot of money that, not my life, I would bet a lot of money, that the cases were in the 150 to 200 that we were seeing. And I assume there's probably some emails or something, you can check it, but.
It seemed like your curve there seemed about, because we were getting the daily, and it seemed like we were hovering in the 50s for a long time, and then once July hit, we just jumped up. I don't think we were, it feels.
Well, that's
I don't think
that's
we were
active
ever
cases.
over there.
Yeah, active cases.
So that,
I'll have to go back and check.
This isn't cumulative cases. This is the number of
I
active
understand.
cases on that
I
day.
just could have sworn we had 150 to 200 active cases back then.
Basically, it increased 5 times from end of June through July 14th. I mean,
And
it's like 2.5 weeks.
It definitely, again, I'm pretty sure it was much higher, and it definitely went down.
Oh, it did.
In the 50 range. I don't have any doubt about kind of May to July, but I think earlier than that, we were running 150.
I think I might be able to.
when somebody recovers.
Might just be.
Yeah, go ahead. Yeah, Adam, if you could just take your mask off. and-
Yep, sorry about
'cause-
that. Forgot.
Oh, sorry.
The mask has become so accustomed.
Yeah,
So I'm thinking maybe that was how many people we had under monitoring, perhaps? So maybe the way that we're reporting it maybe seemed like active cases, because a case generally, back in that time, was averaging about generating 3 different contacts. So maybe that was active people under monitoring at that point in time rather than cases, because that number was significantly higher than our cases. So that's the plausible explanation I can give right now without looking at the data.
Good.
You can see all of the pictures and go back and look. Okay. So we already talked about that one. So let's talk. So indicator number 2 is that we've had a sustained new cases at least 5 consecutive days by date of onset. This is our graph that shows that. Now this one always lags. So while yes, we're a little excited about this if it turns out to be true, these always lag behind because the case gets reported to us, and then we have to interview, and then we know what the date of onset was. So these last few days, you have to kind of look, but you can see, again, this huge curve. So we had a curve here. Mike, can you see what that date is?
It's
right here? Okay, so right in here, we had a little bit of a peak. It looks like right in here, we had a little bit of a peak, and then it went down. So this data, when you're looking at the symptom onset, this is when people show symptoms. Now remember, 10% of our cases don't, but everyone else that we interviewed, and you can see this here. Now, it looks like we had a little bit of a lull right here, but then we spiked clear up. And then these dates will be coming afterwards. Yeah, and you can see from 6/24, we were at 64, and today we're at 242. So huge increase there again. Indicator 2, we have complete data related to that. Indicator 3 is the proportion of cases are not in a congregate setting. So obviously we would want to, if say we had a nursing home that we had 12, 15, 20 people that were sick, we don't want to look at that as 12, 20 people. I mean, we do individually, of course, look at them. But when you put that number in our number, it could really change our number dramatically. Think about Marion again with the jail. If they had only gone by the number, they would have thought most of their entire county was ill, as opposed to just that they just had a huge. So I will tell you, we do not have right this minute, well, let me back up. We have one possible congregate outbreak going on right now, and we're not done investigating, so we have not called it an outbreak. This is our problem right here. We have a whole bunch of cases that are linked to travel, and then they brought it home and gave it to their entire family. So these are young people, not all young, but lots of young, who went out on a trip, maybe to like Athens, which is a real hot spot. Every single person came back positive, and now they're spreading it all to their families. So we have a young person went down, came back, gave it to their family. Now we have 5 more family members who have it. Now these are all epi-linked, and this is one of the things that my association is working on, is we would like to see added to this indicator that the proportion of cases is not in congregate or epi-linked. We'd like that part in there too. We're not there yet, but we're working on that. Because if I could take out those ones that are all epi-linked, it's going to lower down the number of new cases, and that's what we're really interested in. But here's the issue, and I think one of you said this. So this group of children, 20-year-olds, went to maybe Athens. They came home, they were all positive, and they were all symptomatic, because these young people are not going out and getting tested just for the fun of it. They're going because their parents are probably taking
Why
them.
did they get tested?
Because they were sick.
I said, why? If they came back, they're not symptomatic, they say, I want to get tested, or?
No, the majority of our young people were tested because they were symptomatic.
They were symptomatic.
Because they were symptomatic, yeah. So now we have, 2 weeks ago, we have these kids all come back. Now, within this 2 weeks, now we have their immediate families are coming down positive. Now, if any of their immediate families had jobs, maybe they had loved ones that they were visiting, we're going to continue that same group of kids who went, that spread, because it takes a little bit of time to get through. We could continue to see those where they could all be epi-linked, which is why we would like to be able to kind of pull those numbers out. But right now, we don't have any congregate. So what this means then for us is most of our cases have nothing to do with each other, because they're not in congregate living according to the way that it's set up right now. So because of that, we flip that one, because our numbers keep going up and we don't have like 50 of them in one place. Because a congregate could also be like a dormitory. When OWU comes back, if we were to have a big outbreak, that could be considered congregate. So those are the 3 that we've been flipped on ever since the system started. And those are the 3 that I have the data for, and I can take it to the bank because I know that's what it is. The one that flipped us to red is this indicator number 5, and it's a sustained increase in outpatient visits for COVID-like illness, and they receive a diagnosis at the discharge. So it's not like you went into your doctor's office because you had a headache and you left. They're not counting you. Even if you went in for a headache, and headache is a COVID symptom, but if you don't leave there without the COVID diagnosis, this doesn't count. Now, I don't have access to this data. The closest thing I have is out of our epicenter, which is a 24/7, 365 days of the year. This is a surveillance system, but this is, you can see, health provider visits, so by any place. And you can tell we did really peak. It looks like maybe we're coming down. The good thing about this graph, and the good thing about the fact that I actually can get it, this is real-time data. We get alerts 24/7, 365 days a year if we get any anomalies in any of this. So this, it was up, but it does look like we're on the downward trajectory, and this was as of last Friday. The other thing we did talk about, I mean, positivity rate is important, but the R0 is a little bit more important because that's the number of people that one person can infect, and I'm going to talk about that in a second. So the next thing this is really, we can make, I don't know, Mike, how long did you want us to talk?
This is good information.
Is this good? Okay, all right. So this is our EPI report, which you can get online. We do it every Friday. We're getting ready to release a summary report because we are 6 months into this. Probably will be out next week, but I'm going to let Adam talk a little bit about that. Did you keep the thing?
Yeah, I got it.
Okay. Oh, May the 6th was our very first, the numbers, the way we were doing them now, and we were at 47 cases.
What was that?
On May the 6th,
May 6th.
which is the first time we started reporting the data exactly like we were, and we were at 47
Okay.
cases. We were at 153 currently monitored, so that might be where that 150 came in.
All right, so before I get into the data, I guess one thing I just want to say is all the data just has to be taken in context. One piece by itself doesn't tell us really much at all. We have to look at the whole thing, the whole picture, look at what's going on in the community, look at the data points. So just because Delaware County is the richest county in the state of Ohio, it is not the reason that we don't have hurricanes in Delaware County. You know, one statistic is just because it is related to another one, correlation is not causation. And I think sometimes a single data point gets taken out of context. So we'll go through these though, and we'll look at them. And these are numbers that we bring out every week. So this is our epidemic intelligence report that comes out weekly, and I'm not sure if everyone looks at it or not, but we do. And one number, let's see here, median age. So this number is something that we've been keeping an eye on, and it's changed throughout the course of this response. In June, our median age was much lower. The report before this, it was actually 38 years old. So what is that telling us? It's basically what it's telling us is that the folks that are getting sick are changing ages. At the beginning, our age range was 50s to 60s was the majority of our cases. As the response has changed, 20 to 29-year-olds are becoming the majority of our cases. So what concerns me about that, it doesn't, you know, the younger you are, the less severe the disease is, which is great. What concerns me about it is 20 to 29-year-olds, are they going to mom and dad's house, and then we'll have secondary infections that result at the household. So that's the reason that we're trying to keep an eye on that and watching how that changes. As Sheila said, this has been to do with trips. Folks are getting together, they're going on trips, and they're coming back, and multiple folks are having the disease. The other big, I guess, culprit is folks, when you're visiting family and friends, instead of visiting 7 different households in one day, visiting one household might be the better choice. So just some things that folks aren't thinking of. It's not on the top of their mind sometimes, and that's why we're really trying to focus on not don't do anything, but how do you do it safely? And that's what all of our messaging has kind of been moving towards, is how do you visit with your family and friends safely? How do you go to school safely? How do you go to work safely? And how do we, as a community, just think about this in a different level? Not let's shut everything down, but how do we do it all safely? The asymptomatic number here pretty much hasn't changed throughout the entire time. About 10% is pretty much where we've been riding throughout this entire response. We did report our 13th death just this previous week. And you can see there's a big difference in median age of death compared to median age of illness. So it is affecting the elderly at a much worse, more severe way. The map showing cases isn't really something I would jump out at me, because, I mean, we all know your biggest populations, Delaware City, Orange Township, Genoa Township, Liberty Township, and Powell. Right now, it's pretty much following where we'd expect it to, because we know there are more people there. We know that the where the population is higher is where we're going to see more cases. So again, correlation doesn't mean causation in this case. It's just statistics, or it's just information we're trying to share. By age group, this is what I was talking about that I really find interesting. And if you watch this number, if you go back to our first Epi Intel report that came out in May, you're going to find this age group right here is these two right here, number 1 and number 2. And they slowly go down, 40 to 49, 50 to 59, and this 20 to 29, you can watch it continue to rise. So what that tells me, more than anything, is it means that that's where we need to focus our education right now. Because there's some portion that we're lacking in our education. Are we not putting it out on the right media? Are we not putting out the right messages? But that's what that is telling me, is I need to focus more on this age group to tell them what they can do to go out and do the things they want to do, but do it safely. Again, hospitalization by age group. I remember we saw that the 80s were our median, so it does happen to have the most folks who are hospitalized. And then our second is 50 to 59. Again, this kind of follows the trends that we've seen nationally. With the older you are, the more chances of severe illness. So the other thing we look at is how is it affecting different populations. And if we do look at this, and it's kind of hard for me to see it, but let's see, our black is 6% of cases, but only 3% of the population. So, you know, something's going on there. Why is it affecting that population more? I don't have a conclusion on that. I don't know if it affects that population some biological way. I don't know if it's the way that the living arrangements are, the work life. I don't have that reason. Again, this is just data that we're putting out there because we have it and we want the community to know it as well. Sheila's going to go over this, but before she does, I want to talk about two different things that have come up as everyone's been talking as well. Currently, the state is doing what they're calling the COVID study, and they're doing it with Ohio State and the Ohio Department of Health. And they're going to 1,200 random households throughout the entire state. And what they're doing is they're doing both a diagnostic swab and they're also doing an antibody test. And what this is going to tell us is what is the point prevalence of COVID-19 in the community. So it's going to be large enough to be randomized or to be representative of the state. In other areas that I've seen this done in Indiana, it was less than 5%. In a couple of Georgia counties, it was less than 5%. I don't know where we'll be, but to give you an idea, to have herd immunity for COVID-19, we need 60%. So I very highly doubt we'll be anywhere near that number when this COVID-19 study is completed by OSU and ODH. The other thing I just wanted to talk about was something that came out of Johns Hopkins. And they were estimating that one illness usually lasts between 7 and 14 days is how long the person is sick for. So, you know, one of the things to keep in context there is that means we're keeping folks out of, not even us by isolation or quarantine, but if the person's sick, that means we're losing work time from these people because it's 7 to 14 days that they're staying home. We're coming close to 1,000 people. So, you know, if the average person is sick for 7 days and we have 1,000, there's 7,000 work days that we're missing. So we're trying to get in front of it. We're trying to prevent those extra illnesses, trying to prevent any extra burden on the community because that's, you know, that's what we're here to do. We're here to step in front of the disease burden and try and protect the rest of the community for it. And I can say that Sheila and I have both been on the front lines. Before we even knew what this disease was going to be like, her and I were both masked up talking to folks who had it before we knew whether the death rate was 2% or 50%. So just know that we're here to help you guys to answer any questions. We work with you all through RPC, through sewage treatment systems with Mike on the Community Health Improvement Plan. So know that we're here to partner with you on anything and to answer any questions as well. With that, I'm going to back up and give it to Sheila.
All right, so just a few final words, I guess, and then we can, if you have more questions. So, of course, there's a lot of controversy about masks. There are some people who say there are millions of studies who say that they don't do any good. There are other people who swear they do a whole lot of good. You know, we're never going to convince the people who say that they don't do anything. We're just not. They're just not going to believe that. There are studies that show that masks work. I will tell you, I've been a nurse for a long time, and I worked on oncology units for years and years and years, and we wore these kind of masks. I don't even think there were N95s back there, but to protect our oncology patients because we didn't want them getting sick. We also, if they had to leave their room, we put one of these masks on them because you didn't know who you were walking by. And I think by all of us wearing the mask, that's those barriers. And so one of the things that Adam and I are working on, and there's been some recent studies, because there are people out there doing these EPI studies, which is wonderful for us. That's kind of what Adam was talking about with the partnership with ODH and OSU. But there are studies now that have been done that show that if we have 2 barriers on or more, our likelihood of getting sick is very, very reduced. And so the most recent one was in a hair salon. They had 64 people would have been considered close contacts. They had 2 hairdressers that were positive. Every single person had on a mask. Obviously, they were in there for much longer. None of those people were positive because of the mask. And so we've made a decision in the last week. We haven't started rolling it completely out, but when we're talking to people, because again, we want to keep people back at work. We don't want to close down restaurants. We want people to be able to do this. Like Adam said, we want people to be able to do the things they want to do. We just need them to do it a little bit with a little bit of a caution in their heads. So we've made the determination, and moving forward, we'll be rolling this out, that if you and I say today, I were to come down in 2 days, because it usually takes about 2 to 3 days for me to show symptoms. If I were to be sick, and so Adam's going to ask me when he calls me, where have you been in the last 48 hours? And I'm going to say I was at this meeting, and he's going to ask me, well, who all was in the meeting? Then he's going to ask me, well, tell me a little bit about your contact, and I would say, I was not within 6 feet of any of them. Most of the time, we all had masks on. And even if we didn't, like you all haven't had masks on, but we're 6 feet apart, and when I'm wearing my mask, that's 2 barriers. And so anytime that you have 2 or more barriers, we are not going to consider you to be a contact. This is really, really important as we roll this back out with the schools. You know, we've been working with the schools for months, and they're all doing an excellent job of trying to get really, really good plans together. But it's going to be real important that in the upper grades, this is going to be harder in the lower grades, but say 2nd grade and up, it's going to be really important that that teacher stays behind their desk. You know, that we want them to be 6 feet away from those kids. They are going to, most of the schools are going to require masks for all of the kids. Not all of the time. They're scheduling mask breaks and all of those kinds of things. Again, going to be harder when you get to the littler children. But every time we can put a barrier between us, that's one less risk that we have of coming down and being sick ourselves. So we're getting ready to roll that out. The governor has asked everybody when you're in an inside setting to wear a mask, if you can, because there are people who certainly can't. But if you can't wear a mask, stay socially distanced. Adam and I left our building down there. He had his mask on as we walked around the corner. I had mine off because we were standing 6 feet apart and we're outside, and the governor's order says if you're outside and you can socially distance, you don't have to wear a mask. So we're going to work on those messages and try to aim those messages a little bit to our younger kids. We do know it can go on surfaces, but the transmission on a surface is much less likely than it is if it's airborne. The R0, that's the infectious rate. So just to put it into perspective, because this is a novel virus, and we're learning more and more, this number has changed a little bit. But right now, 1 person is infecting about 2.5 people. The flu is 1 to 1. So Commissioner, you asked, why would we think about maybe doing some of those things? Actually, if you get right down to it, it's actually spreading a little bit more than what this is. But then you look at measles. When we have a measles outbreak, and we have had several in Ohio, 1 person can infect 18. And one of the problems with the measles is it takes us at least 4 days before you are infectious, 4 days before you become symptomatic. So you're out there for 4 days wandering around breathing on everybody. The vaccine is in development, like Adam said. In order for us to have herd immunity, we have to have 60% of our persons. Now that could be 60% of the people had it, or the vaccine, or a combination of both. The only thing we don't know yet, and there are studies out there that are looking at this, is we don't know how long if you had it, your immunity lasts. So that's why these antibody testing is important, even though it doesn't validate. We don't count those in our confirmed cases. Antibody tests alone are not counted in those. There have to be other factors. But it is important to do those studies because it's going to know. I think the latest study I read is that those antibodies wane after about 2 months. 3 months now? Okay, 3 months. So we are going to have to really work with our community to get our vaccination rates up. You know, I get kind of tired, I think, of people saying this is our new normal. We just need to be safe. You know, we all put seatbelts on. You know, we don't drive down the road drinking a beer. So we just need to maybe think about what can we do to protect ourselves and protect the people that we love. And then we've already talked about the positivity rate. These are the states that the governor just put in if you've gone to any of these places. Now, it's a requested, it's not a requirement. You don't have to call us. We're not going to call you. I mean, how would we even know? We certainly will answer your questions if you want to know what that means. But if you travel to any of those areas, he is requesting that you self-quarantine for 14 days. We do have lots of resources. I believe, well, I know for sure that the commissioners all get our newsletter because it started out as our district advisory newsletter and it's morphed into this additional thing. We do have specific pages on our webpage related to COVID. The Epi Intelligent Report comes out every Friday, and like I said, in the next couple of weeks, you'll see a 6-month summary with a little bit more analysis. Of course, ODH and the CDC have information out there. If you follow us on Facebook, you can read all of the armchair EPIs that have all of their own opinions about all of the data. Tracy Whitaker forbids me from reading it because it just makes me upset. But anyway, so we hopefully are giving you all the data. If you go to our website, which I would really encourage you to, you know, I know everybody's concerned about the economy and what has this done. And, you know, personally, I'm concerned. You know, my husband retired. I think I shared this with Commissioner Merrill on the phone. He retired to follow me over here when I took this job, and he took a lump sum of his retirement. And his whole life he worked. His parents, very, very poor. His whole life he worked. And the sole purpose, he wanted to be able to leave money to his kids. And with all of this happening, there's not going to be very much money maybe to leave. And so that's very distressing. It's very distressing to us. You know, we hear horror stories about some things that are going on around the state. And you know, we have 113 health departments, and I would tell you that I probably know 60 health commissioners face-to-face without any problem, and probably the rest of them. And there are some bad things going out there. We heard last week that one health district had one positive person in a restaurant, and they shut down the whole restaurant. There's no reason to do that. None. Now, they may want to shut down for a couple hours and do some intense cleaning. You know, I got a call from someone last week that one of our restaurants on 23 was shut down, and they wanted to know, was there a positive case and did we shut them down? I said, well, first off, I'm not going to tell you if there's a positive case or not. That's on a need-to-know basis. But very rarely do we have to shut anyone down because they voluntarily do, because our business owners are working very, very hard to do all of the right things. I was appointed to the governor's task force for the restaurants and bars. We are still meeting. Our task was done whenever we reopened restaurants, but we meet every single week to talk about what's going well across the state, what's not going well. That's where I hear about these horror stories, and then we, you know what we say, there are 4 health commissioners on that, and then another public health person. We say to those people, you tell us, email me and tell me who that is, and we will reach out to them and talk to them, because there's just no sense in doing that. And again, if we're all practicing the things that we need to practice, that even lessens that a little bit more. We have had people that were positive that worked in a restaurant or a bar or a business or a school. I mean, we've had all of them. Jeff can attest to that. We've done a lot of testing and we've done a lot of contact tracing. But we try to look at each individual case and then determine what is that level. You know, when we talk about the 10-day isolation, we talk about the 14-day quarantine. If you're a household member, that can actually end up being 24 days that you're actually out, because as long as you are in contact with that infectious person, you could develop the illness, which is why we have to wait 14 days after that person's out of isolation. But we work with the person, and if they can stay in their room, have a separate bathroom, not come out, not share anything, which means they can't be taking their dishes back and forth to the kitchen, we will work with you to see if we feel like you were separated enough that we can decrease that. I've had families, people call me and we talk, and, well, what if we move the sick person to a camper? Absolutely. You do that, then your 14 days starts today from your last contact. Well, day 0 is your last contact. So we're working really hard. If you go to our website, there are all these different sectors. We've put toolkits together for all the sectors with checklists for everybody for all the mandated things. We try to give them the best practices. We have 6 staff right now that 100% of their time is answering questions for the businesses and the schools, because we want them all to be successful. We want you to be successful if we ask you to stay in isolation or quarantine. You know, the last thing that we want to do is shut anything down again. I mean, I personally believe we would have a really hard time if we have to go backwards. The last thing I want to leave this on is the purple level. So in the red level, there are 2 indicators. So it's 4 and 5, not number 4 and number 5, but you have, if you get to 4 or 5 indicators, you go to the red, which is where we are. We're at number 4. If you get that 5th one, they actually star your county, because that means you're 1 step closer to the purple. There is nothing actionable right now when you get to purple. What the state has told us as of last Wednesday at noon, I always try to clarify now the numbers, as of last Wednesday at noon is I will get a call that we're going to flip to purple, and then it will be our community will decide, and that would mean our elected officials, we will decide what that means for us. We have a county south of us, one of our city health departments who has already told a couple schools that they cannot open. So I had a couple superintendents call me and say, what are you going to do about that? I said, that's going to be a decision that we will make together. If at whatever point we don't believe we can bring children back to school safely, then we have to stop. But as long as we believe we've got good plans, we're doing all of the right things, we're going to do everything in our power to keep that safe for those kids. Those kids need to be in school now. Long discussion we could have about if they can't really interact, is it as valuable as it, you know what, they still need to be in school, because we know we have lots of kids who are in such horrible situations that being at home is not a good place for them to be. So appreciate the time. You know, we're working with the city, with PAL, with Sunbury. I mean, you know, all of these partners. Everybody, I think, has Jeff and mine's cell phone number now on speed dial, and Glenn's. We're all, they call us 24/7. Mike texted me, I think it was 10 o'clock last night. So, you know, we really are trying to make ourselves available. Tracy yelled at me the last time I did this because I actually had my cell phone number. I said, my cell phone number, if you call my office, it's on there, so why would I not put it up there? But I had to make some room to put Adam up here too. So thank you for giving us this opportunity to talk, and if you have other questions, we'd be happy to try to answer
Go right ahead. This is a topic we could go on for hours on, obviously, but.
I'll make it quick. First of all, Adam, Sheila, thank you very much and putting up with us. And the charts have kind of shown a decrease in the last, I don't know if that's a couple of days, 3 days, or whatever the number is. So I think the question that a lot of people would ask is, how long will those numbers have to be in that decreasing form before we move down a level?
So that, of course, obviously will be up to the state. They tell us that they're looking at that on a rolling average. You have to remember, even though those numbers are down the last couple days, the data always lags just a little bit behind it because of the test results getting in. I was just telling Jeff that we were on a 7:15 call this morning with the governor, and I heard from one of my peers that in some counties, the hospitals and the laboratories are so far backed up that they're not getting the data entered, the test results in. So then, of course, we can't start anything until we know what the test results are. So there is a lag, but it does look better. We were at 287 active cases, I think, just a week ago, and today we're at 242. So that's better. And those are cases that we've already interviewed.
So you didn't really answer my question, so maybe you can answer it. Is it 2 weeks, 3 weeks?
I don't know the answer to that.
Commissioner. My wife came to me this morning and gave an example. I won't tell you what she thought about the example she gave me. I believe she said it was in Delaware. Somebody goes through a drive-through not wearing a mask, they refuse to serve them. Is that appropriate under these guidelines or not?
The business owner would have the authority to do that. That's the business.
Okay.
And we've been asked that question. I mean, I've gotten emails from business owners
First time I
saying.
ever heard of that when she mentioned it this morning.
But
It
if
seems a little bit
somebody-
over the top.
But that would be, so this is what I would tell you, we have on our website a place people can put concerns in, and then we'll have somebody who's addressing all of those. We can reach out to the business and make sure that they're aware that if somebody's in a drive-through, there's very little reason for that person to have a mask. If I'm in my car all by myself, I'm not going to have a mask on. Why would I put it on just to talk to someone through 2 pieces of plexiglass? So we'd be happy to reach out to that business owner and have a conversation.
I don't have no idea who
Yeah,
it
but
was.
it's
She
up to
didn't
them.
say, and I didn't ask.
Yeah,
but,
they can do that. It's their business.
The, one last question, I'll shut up. The quarantines don't really factor into these 7 levels, I don't think, do they? People being in quarantine?
No.
But I am curious, what percentage of people in quarantine actually turn out to have the COVID illness? Anybody have a clue? I'm just curious.
We're looking at that in our new report, aren't we?
Unfortunately, I don't have that number right now. We've been trying to look at it. We had the great intention of doing it, and then the cases kind of blew up on us. So we hope to get a little study of our own population on that, but I'm sorry, I don't have that number. And just to piggyback on your other question, I used to be a food inspector, so I know that restaurants sometimes say you have to do this because the health department says so, but I'd go in there and be like, I never said that you guys had to do that. So sometimes it's easiger for them to use us as the reason why,
We can
and we can
appreciate
take
that.
it.
We're there a lot.
Yeah, we get blamed for the schools and water.
We've got the shoulders to take it, so.
Yeah, thank you.
Thank you.
And just so you know, summer was ruined and it was my fault. So just so you know, it was my fault.
Okay. All right, well, thank you. Again, thank you.
Well,
for
I'd
all
just
you
like
do.
to thank you, too. I'm going to pop in here. I mean, I think the information that you've given us has clarified a lot, and, I thank you for your dedication. I mean, day in and day out, day after day.
It has been a long time.
It's been a long time. But I think, too, that one of the most important things is when people have questions, they need to look at the website, your website. I mean, it's got so much on it, and then people are available, too, as you said, to answer questions. So I would just urge people to look at the website, ask the questions.
Yeah, I will say we did it at the beginning. We had actually a general phone bank people could, and then it just really weaned off. We've actually talked in the last little bit about getting it going because our epi team right now, I think we have 28 people on it. More than that, we're bringing on, I think, 4 new contact tracers. We didn't talk about that. Maybe I should just mention a little bit about that. But anyway, they just are so busy with the cases. They don't have time to just answer general. But if people have a concern, they can put it in our on our page.
Okay.
Somebody will answer all of those. Okay. What we try to do, too, is to look at what those concerns are and then make sure we do a post or something about that. Honestly, Commissioner, people call me and ask me all kinds of things, and a lot of times it's the what-ifs. I was here, this is what I heard, what do we need to do about this? And we know that that's just going to continue, especially as we get back to school. But they are always welcome to call, and really, my cell phone is out there, so. But something you said reminded me to say something else. Oh, just a little bit about contact tracing. So contact tracing is just one piece of this, the whole investigative piece and stuff, but all of that does get wrapped up into contact tracing. So our entire EPI team, although we break them up differently, that is what we would consider our contact tracers.
Right. I mean, just, I guess, to be concerned about if someone goes certain places and, that is a real concern, because if a place isn't clean or, whatever.
Well, and I would say, just like with other
Get the
communicable
origin.
diseases, as Adam said, we've always done this. If we believe that you are a contact, we are going to call you or send you a letter that says, you were at this place and this is what we believe. Somebody wanted to know, well, why, if somebody had been at Walmart in the last 48 hours, why aren't you putting out? If you were at Walmart on such and such and such and such a date, well, because that's casual contact. I mean, it's very unlikely, unless somebody sneezed right in your face, that you're going to have any kind of a thing. And even the cashiers now, I think they have plexiglass, so even they have it, even if somebody else doesn't have a mask. So again, just thinking about the way that the disease spreads, so we're not going to do that. Now, with some diseases, we would do that. Say if we had a measles, we would definitely put out, if you were at Walmart on such and such a date, you need to call us. When we had the measles, we actually did vaccine clinics that Saturday because we know if we can get you that vaccine within a certain, and we put it out there. I mean, it was everywhere. If you were here, you need to come and talk to us about getting another vaccine. But with this one, because we know we have community spread, we expect that our community, I don't know where they would be living if they didn't know we had COVID right now. My husband wants to move to Australia, I think you said. But anyway, so we're not going to do that because it's not spread casually. Now, the owner of the operation, if there's a positive and we have reasonable belief that the person's going to try to go to work, we would call them and say so-and-so cannot come back to work until such and such a date. We don't tell them what the disease is. Right now, people are probably going to guess, but we do that all the time. Pertussis, TB, all of those kinds of things.
Thank you so much.
Again, thank you for coming and keeping us up to date and continue to keep us up to date. So.
Well, and anytime you want an update, please.
Oh, yes, that'd be great.
I think Councilwoman Keller also wanted to address the commissioners for a moment about this topic too. So.
Thank you so much, Commissioners.
You're welcome.
You know me, but for the record, Councilwoman Keller, I'm from the city of Delaware. And I've had the pleasure of speaking with your incredible administrator, Mike, over the past few weeks about an idea that I have for an intergovernmental countywide task force to help us deal with some of the situations that we've been presented with this pandemic. I think Sheila Hiddleston and her staff have done such an amazing job for our county during this really just a difficult and unprecedented time for us. I'm tremendously grateful for her incredible work. Right now, I see us as different jurisdictions operating very independently of one another. A potential issue with this is the governor's indicator system. And many in our jurisdictions, I think, lack a understanding of exactly how these indicators trip, what data goes into exactly what will cause us to move from orange to red to purple, and what that will mean for our businesses, what that will mean for our citizens as we move through. A lot of us are just kind of flying blind, getting information as we go. When these indicators do trip, we're all being judged together. So if there is a situation happening in one jurisdiction that may be contributing to these numbers, it's going to affect the businesses that may be in a different jurisdiction that may have much lower numbers. Because we're all red together, we're all orange together, and if we move to purple, we're all purple together. And so without a framework to really strategize and collaborate and dig into the data and make sure that we all understand how we're being judged and what goes into these numbers within our individual jurisdictions, we're not really giving ourselves the best chance at having the best outcome for our county. If we worked within a school and we got the statewide indicators, the first thing all the schools would do is sit down and say, these are the things that we are being judged upon. So what strategies can we come up with? How can we collaborate? How can we better understand how this data is being used so that we can be proactive instead of reactive and not wait to turn to red or wait until we're in a purple situation? Perhaps there are things that we can do now to work collaboratively to prevent that situation from happening. Just digging into the data myself, there are a couple examples of some things that stuck out to me. One of the things was we have a much higher probable percentage than a lot of other counties, 20 to 30%, compared to, for example, Franklin County at 4%. And I've talked to Adam a lot about this, that one of the things that jumped out in my mind just from a data perspective was that's a statistically significant number. And 3 of the state indicators are judging us based upon what our number of cases are. And if 20 to 30% of them are probables, what if we sent each and every one of those for a test? Now, Adam said that that potentially puts other people at risk, but are there options for drive-up testing or things that perhaps we could coordinate so that we could lower that risk? But the benefit to us would be if we could eliminate people from that number, then that could prevent us from tripping some indicators perhaps.
So these are just some of the ideas that I have where perhaps a collaboration or something where we were working together intergovernmentally, we could look at these indicators and say, are there opportunities here for improvement? Could we reduce some of these numbers? What resources could we pool so that maybe from an outside perspective, there are things that we could bring to the table to give assistance? I would view this as something where the health district would certainly be at the core of this. I wouldn't view us as operating outside of the health district. I'm volunteering myself to help organize this with Mr. Fromer. I think that given the urgency of the situation that we're in already in red, that we probably don't have any time to waste if we have your blessing to get started. I would envision this as maybe some of the bigger jurisdictions at first. Let's get together. We can meet remotely and talk about some of these data issues. We can see what we can do to provide assistance with the health district, and we can help work together as a county so that we have a concerted and coordinated approach so that we can get better outcomes collaboratively.
So I think what you're saying is this would serve two purposes: communication and ensuring the accuracy of the data and doing what we can to mitigate, like the probables you mentioned.
Absolutely. And if we get into a situation where, let's say the state doesn't provide the data that they promised on August 1st, then we are much more powerful as a county to help Sheila, to stand behind her and to say, as a county, as the city of Delaware and the city of Powell and Orange Township and Liberty Township, all of us united are letting the state know this is important information. We need this information to help our businesses, to help our economy. And if it's Sheila standing by herself, that is a lot less powerful than if it is all of us together as the different jurisdictions saying, for the health and safety of Delaware County, this is information that we need, and we need the state to provide it, and we have a framework here to help us communicate that and put pressure when we need to ask questions when we need to, and to provide support when we need to.
Okay.
Could we ask Sheila her opinion of this?
Sure, sure. Sheila, your thoughts on?
Sheila, your thoughts?
I think it's an interesting concept. I feel like we're already doing a lot of that, and we're working. So, for example, when the swimming pools were going to be able to be opened, we had calls with all of our public, not the apartments, but all of our public, and Ryan Rivers from Orange Township actually called me and said, do you think you could do this? Could you poll us all together so that we're all on the same page? We've done the same thing with the business. Chief Pijanowski and myself, we had a big call with all of our downtown businesses about how are we going to open, how are we going to open up safely. And I guess the one thing I did say to Councilwoman Keller when we were sitting out there and she kind of floated this idea is it actually in some ways might make our lives a little easier, because instead of talking to 20 people about the same thing 20 different times, that might be better. On the flip side, I feel like we're already doing a lot of this, so I would want to make sure that the way that I'd have to think a little bit about how do you do that to make this effective. I was sharing with her, we were on a call with the governor this morning, the health commissioners, and when you have that many people all trying to talk and all trying to share the things that are of concern to them, we did spend a considerable amount of time talking about the data and the risk systems, and actually I was asked to speak about the risk levels and the data, and I told him, I said, you know, Governor, if I don't have that data that you're based on, it's very hard to stand in front of my community and say, I can rely on this data and we're all completely here. And he said right then to the Director of Health, when are they getting it? And we've been told we're going to have it on August the 1st. So,
2020?
you know, pardon me?
2020?
That's what I've been told.
Sorry.
I mean,
Had to throw
the
that in.
truth is, we have a statewide data warehouse that we can get a lot of data out of. We just haven't been able to get this data out of it. So I think there's some merit in looking at it. I did say to Councilwoman Keller, we already have this mechanism. We have the DAC, which is made up of one of you, every president of every township, every mayor of every municipality. We already have that mechanism in place, and we give you quarterly reports about a lot of this, and then, like I said, we turned our newsletter into that. So we have certainly a mechanism. I mean, I have a group, and I can send them all out, which I will share with you that as soon as I was notified that we were going to red, I did send that email out. I will not be doing that again because somebody leaked that information to one of the bubbles, and I got a call almost immediately. So I will call people like Mike and let him know, and I know the governor's all of you all, so, but at any rate, I'm not sending it out via email the next time. So I think there's some merit. I think we would have to think about what does that really look like, and what would be our purpose in doing it. You know, I don't really feel like I need somebody else to look at the data. If there's additional data points that we need, that's what I need to know. If somebody wants to see, like what you just asked Adam about, the number of people who are probable that become an actual case or a confirmed case because they're tested. I did want to just let you know, though, that the reason that we probably have more probables is because we have more people in our county who go to the physician. And that, I mean, we know we don't have as many people who are without a provider, whereas when you look at someplace like Franklin County, they do have a large portion of people who don't have a provider. So they probably wouldn't be diagnosed as probable because they aren't seeing that EpiLink. I think that that's probably one of the reasons our number would be higher, just off the top of my head. That might not be true, but I think that that would be one of the reasons. So certainly could see some value. I'd want to know a little bit more about what the purpose of the group would be.
My comment would be, you're not opposed to it.
Oh, no.
And I do think there is misinformation that, you know, we talked about some of that this morning.
A lot of questions.
I would like to ask if Sheila and Lisa and Mike could just maybe have that conversation and see what is feasible and makes sense, and then you can give us an update. And I'd be proactive. I'm good with that process. I think there are some gaps that they may be able to feel better than you, because you're looking at the whole county. They're talking about the smaller universes that they would see more quickly, perhaps.
So we do have one of our staff members, again, this has been going on for, 3-4 years. Each of our townships, municipalities, all have a staff member that's assigned to them. And even though we haven't been visiting meetings during all this because they're so busy they can't go to another meeting, we're still keeping in touch with them. And so, like, I just had a whole email conversation with Troy Township because they had a couple of questions, and their representative is not knee-deep in all of this. She normally works for WIC, so they send the information. So we're still in contact, and we've always done this. I go to the meetings, my staff go to the meetings, so we are kind of already talking to them about what are their needs and things. And now we don't do that collectively by bringing the whole group together virtually, obviously.
So you've already got a system set up?
We have a system set
Yeah,
up to communicate with
which
all of our
is-
subdivisions.
Right, yeah.
And I thought you did an outstanding job of getting the communication going and then continuing in the early stages when there was so much unknown and
Thank you.
people just didn't know. And, you know, your weekly calls and everything, I thought you did a great job of
And
doing
we
that.
did stop the weekly calls because it seemed to kind of
Yeah, again.
down a little bit, but we're doing them monthly. So actually, I think, I don't know what today is, but whenever the first Wednesday in August is, whether that's this week or next week, we will be having another one. You know, I'm never opposed to any way to communicate better. In fact, I think one of our staff was listening to your previous meeting, and there was an issue brought up, I guess, about communication. And I mean, she just takes that to heart because they just work tirelessly trying to make sure that everything everybody wants to know, we get out there, and all these toolkits that have been developed and things. If you're interested in the schools, we just publicized, we haven't publicized all of the toolkits, like the whole thing, but we did just put the school one out there, the school one out there on our website because we're getting so many questions from parents.
Yeah. So I think if Lisa, if you want to, with Mike and get, you know, some of the township trustees, you know, the big township trustees or whomever, Sunbury, engaged and work on a list of things that could be communicated researched, I think that'd be great, because you're frontline, we're all front lines, and we get questions different than I'm sure the health districts get and have questions ourselves, so.
Already started putting together a list of people who are plugged in and willing to serve.
I think
So-
that'd be up to you.
Well,
I think Mike would be.
I think it's one thing to have, talking with people and getting questions and everything, but the idea of a formal task force separate from the health district, what you're running into there is, who's going to be on the task force? Do they have the expertise to serve on this task force? I mean, this is something that is, you really do need medical, scientific training, and I think it's fine to work with the health department. And again, you've already got a system set up where you have representatives from all the townships. I would not support a separate task force. I think too, you run into a problem with somebody saying, well, I'm on the task force and I think this, when they don't have any medical or scientific training. And then people listen to this, it's like, oh my gosh. I really feel that this has to be run through our general health district.
Well, I think Sheila was part of the equation.
I wouldn't see it as, I don't have any medical training at all, so I wouldn't be telling the health district what they should be doing with their reporting or with their data collection or anything like that. I think that it would just be a working group, call it, instead of a task force, of how do we collaborate better and how do we achieve better outcomes. Getting these questions answered, digging into this stuff, and having a place to do that, so that if we're we make decisions as a government. If our DORA in Delaware is spiking cases within the health district, and that causes us to move to purple, and that's having an impact on Powell, who's deciding we're not doing a DORA, then maybe this working group gives the chance for Powell to say to the city of Delaware, hey, listen, why are you making these decisions within your jurisdiction when we're making this decision within ours? They're not aligning. I think there's a lot of opportunities like that because we're all being judged together, but we're not coordinating this between ourselves and Powell. The health district may be, but as government leaders, I can tell you, we're making those decisions on our own, in our own jurisdictions.
And I think it's great that, and Lisa, you brought up a great point about the governmental entities. I mean, we've been elected to lead, and therefore we need to talk to each other more. We need to communicate. We need to communicate with the health district. But we don't need a separate task force, which is outside of a purview that doesn't have this specific training, again, to make pronouncements on this issue. I mean, yes. Go ahead. I can see some real negatives.
Yeah, I think that the technical side of this needs to stay with the health district. I think that this is, maybe a task force is not the correct term. I think it's more of a community engagement to help the health district spread the word. Right now, Sheila and her team is doing a really good job of getting information out there, but Sheila probably has a bunch of one-off conversations with elected officials. I think this would bring a group together with the communities and bring that so that, it makes it easier. And as Councilman Keller said, if there's something, Adam mentioned earlier about educating the younger students or the younger population, what can we be doing then to help with that message? What can the City of Delaware? And it's just getting everybody, I don't want to say people aren't coordinated now, but I think it provides an easier interface for the health district to get the word spread and to work. What's that?
They're a much bigger platform.
Yeah, and I think, and helping with that. But I don't think it's a conflicting technical, data, because that's a discussion with the governor's office. And I'm sure that, you know, we've heard a lot today that you guys would like data by August 1st and, you know, and different things like that. So that dialogue's already happening. I think this is more of a, you know, an integrated team representing the communities to help the health district implement and just understand. I mean, look at, I don't know about you guys, but Sheila went through this and Adam went through all this stuff last week when we met on Thursday. This was very enlightening to understand this information, and I think having this group will help each of the municipalities and townships get this information without each person having to call Sheila and getting an individual tutorial on it. So it's just my opinion.
Yeah, I look at it as an informal group.
Yeah.
Yeah, I don't, I mean.
Real task force.
I don't think task force is the correct terminology.
Yeah.
Informal group for communicating and discussing ideas, and, you know, that's what I view it as. And clearly, the health district needs to be at the center of it because they're the experts.
Yeah, I think to me, I think if this occurs like what we're thinking, I think it would be would help the health district continue, you know, with the messaging and things like that, and get the groups together. And as Lisa mentioned, you know, the DORAs and how those things, and, you know, different things like that, communicating between municipalities is really important as well. So.
Yeah.
I'm just going to add, you all probably know, but we do have our PIO group that meets regularly. And
Yeah.
we've been so fortunate. Gosh, I keep doing it. We've been so fortunate that they are, I mean, everybody's in lockstep with each other and messages, and everybody's sharing them, and that's been really good. And while it may not appear that these other groups are all meeting, I mean, I've talked with Andy White over in PAL, and Tom and I certainly have talked about the DORA here. We sat down at the very beginning, and I guess my assumption is that Andy's probably called Tom and had those conversations. So I think some of that is happening, but maybe the rest of the world doesn't know, and so maybe the value in having this group would just be make sure that everybody knows that everybody does know. That maybe doesn't make any sense, but because I will tell you, that stuff is all happening. I mean, everybody's talking with each other. If they have the pool, we all talked with the doors. We've all talked about the farmers market with PAL and Sunbury and us, and how are we going to do all that. But, you know, Orange Township knows all about the pool because they were intimately involved in that one, but they probably don't know very much about the DORA because it's not, although I think there is a little tiny bit of Orange Township. Jeff always knows these little tiny bit of Orange Township that's in PAL addresses. Seems like when we do our line list, we have to talk about that. So I think all of this is happening. So if it's just a forum to make sure that everyone kind of knows that it's happening, or they could ask, well, how did you all come up to this decision? I mean, I'm already meeting with all of the superintendents about how are we going to do this for schools, and how are we all going to stay on the same page, even though all of their boards have decided to do things a little bit differently. But that's why we have the best practices document for them. So, you know, I mean, I'm certainly never opposed to talking. You all know me. I love to talk. I'm a little exhausted some days from talking, but anything that makes it better, we're always wanting to make the communication better. I don't want this to be something new. It's not a group that's going to be making, you know, the decisions about what we're going to do, because obviously, in order to do something like that, you would have to have representation from every single.
Or I think making pronouncements on certain things, and it's one thing to have a web of communications and making sure everybody knows what the other person's doing and offer suggestions like that, or, you know, which is already being done through our public information officers too.
The mayors have an
and our
association.
EMS.
The mayors, they have an association where they meet regularly. I think so.
I think we need to take a look at what is there already and work, for instance, with Jane and the PIO group that's already there with our EMS, and then if we want to bring in other people to talk, I mean.
Well, you know, I think we're missing the point. At least I think no one is suggesting the health department doesn't have the authority. All this group is going to do, my understanding, is try to provide a conduit to improve communication. We get emails all the time, people are confused. And what happens is, what's happening in other counties in other states gets represented, it's happening in our county. So if it's not happening in our county, having a group out there that is able to minimize and facilitate is a good thing. Because there's so much generalization that's occurring. You know, the guy who died in a motorcycle wreck that had COVID and they were counting that number. Those kind of things are going on. I agree with you. But that's what's being generalized. And all I'm hearing is this group wants to be helping the communication, to bring the temperature down, make sure we're all on the same page. I don't see a downside, so that's my point.
And Commissioner, I have no doubt that this is not an authority question. I don't know if I've said something that made you, no, this doesn't concern me at all in that respect.
Yeah. Well, once again, I think that all of our public information officers would need to be involved in this. They do have, as far as outreach to different parts of the county. Certainly if Mike, if you and Lisa and whomever, Jeff, obviously the health department want to meet, I guess I would certainly feel better if there was more buy-in from the existing structures that we have, because we've got those people that are already in so many instances doing things. Could there be better coordination? Yeah, I'm sure that there could. That's fine. That's the way we left it, that we were going to talk, you were going to talk.
I think one of the things perhaps, and maybe we've not done this, but you just made me think maybe we need to do this. So one of the things we wanted to address with you all today, one of the things we wanted to address with you all today is the misconceptions, and what you're talking about is a perfect one. We have not put out an FAQs document to all of you all that says, here's the answers to these questions. And, regardless of what we end up doing here, we could do that. We've come to the point now where I have a pat statement if we get a call about this or this, because it's just too hard. Plus with 75 staff, I also don't want 75 staff giving 75 different answers. So if we've come with, this is our stance on X, Y, Z, and then, I make sure that all of the staff know this is our response to this question. And we have worked on FAQ documents that we've used internally, but maybe we need to do that, and it would be very helpful, regardless, again, of what we do with this, be really helpful. If you're getting the same question 20 times, shoot me an email, text me, and say, hey, make sure that you address this one so that you could have, kind of this is the truth here. Most people, once you tell them the truth, they kind of back off some of that kind of stuff. But
We only know what we know, so if there's a small group that can maybe alert you to something you weren't aware of, hadn't heard, then that's a good thing. So that's the point, I think is what I'm hearing.
And I would really be interested in what people don't think that they know, because I know that's where Tracy, when she heard the comment from the last meeting, she's like, I don't know what they're talking about, because we communicate all of these different ways, and, and so if you're hearing something that you don't think the information is out there, maybe they haven't gone and looked for it, like you said, but we would love to know what those issues are. And so if this can be a forum to kind of make sure that the questions that you all are getting asked, we're making sure that we address those. That certainly would be a good use of that type of a forum.
Okay. So we'll rely on Lisa, Mike, you guys to kind of work on this, and don't want a task force, don't want a new formal organization, but I think there's definitely some ideas that could work well to communicate better. Clearly, the health district needs to be.
This is communication, so I definitely would want our PIOs involved, because they're the ones who know who get the word out. And so, they have the instruments to get the word out, the technology to get the word out to people that we do want to communicate from the health department.
Adam just showed me, we could actually, and this would be easy, like I said, we have our DAC, that's what they are, it's a representation of every group. We could just we can call them our DAC partners, and then people could jump on if they want. You all were even trying to figure this out. We could do one of those, set up one of those this week. That would be hard.
Yeah.
And, I guess that might help Councilwoman Keller know how much interest there is in doing something like this. Because I do have great concerns that we don't invite everyone to the table. They may not want to come, but I think if we're going to do this, you have to invite everybody to the table.
Okay, well, again, thank you all.
Thank you so
Hey,
much.
Sheila, we both
Thank
missed
you.
Rotary today.
Yeah.
We both missed Rotary today.
Gee.
I can't even tell you how much, I mean, I could probably count on one hand the number of records I've actually gotten.
Okay, so that is it for the regular session, Jennifer? No executive session, thankfully.
Are you finished, or?
So with that, unless there's other business?
Well, I'll just attended a veterans event Thursday night, the Larry Klein
you went to
Awards, and I thought that went really well. Bruce Urian was the award winner this year, and he was totally, Y-E-R-I-A-N, he was totally surprised.
Oh, my.
And it was fun just to watch the look on his face as he was identified and the shock as he walked up to get the award. And I did pass it on to Jane, so she's may be able to use that on our
good.
website or
Yes,
our newsletter. And
yeah.
Larry Klein, as you
Yes,
Great.
that's a real honor to receive that.
great member of our community and did a lot of great stuff.
Yeah.
So I just wanted to pass that on. That's all I have.
Yeah. No, I think anything can be deferred.
Yeah. All right, I don't have anything else either, so with that, we are adjourned.